We're live.
Good afternoon. It's January the 20th, 2022, and welcome to this joint briefing, including the Senate Judicial Proceedings Committee, Senate Finance, the House Judiciary Committee, and the House Health and Government Operations Committee. We are having this as a virtual meeting. Please be patient if we have any kind of technological or streaming issues. And I'll remind members that this is being live streamed on the Maryland General Assembly's YouTube channel. Committee members will be muted through the briefing. If you have a question after our presentations, use the electronic raise your hand function within your Zoom window. We will not be able to see you wave your hand. Don't do this. After I recognize you to ask a question, please unmute yourself, or my staff can unmute your screen for you. Today, we're receiving a briefing on the 2021 Health Services Cost Review Commission's report on the independent actuarial analysis of Maryland's medical liability climate. For this briefing, I would like to introduce the following committees again and their chairs. Welcome Chair Will Smith and the Chair of the Judicial Proceedings Committee, Chair Dolores Kelly, and members of the Senate Finance Committee, Chair Sherry Pendergrass, and members of the Health and Government Operations Committee of the House. And I'll recognize Subcommittee Chair Kirill Resnick and members of the Health and Social Services Subcommittee of the House Appropriations Committee, who are all here today. We're going to hear first from Stephen Coca, who is the Principal and Consulting Actuary at Milliman, the group that did the study. They're going to provide an overview of the HSCRC's Hospital Liability Report. He's going to have 30 minutes to present his remarks. After his remarks, we'll open the floor to questions from committee members, and I'm asked that questions are related to Mr. Coca's overview only. There'll be, I believe, a PowerPoint presentation for Mr. Coca's remarks. Then after that, we're going to hear from the Hospital Association. We're going to hear from the Maryland Association for Justice. And after those two panels, we're going to give the hospitals and the Maryland Association for Justice another 15 minutes as a kind of rebuttal. This is an unusual format, but having said that, there may be questions after both sides make their remarks. So with that, first, we're going to hear from Stephen Coca, and I'll ask for him to begin his remarks, and we will start the clock. Mr. Coca.
Thank you, Mr. Chair.
Thank you.
Dylan, do you have my slides up? Thank you. So to introduce myself, I am Stephen Coca. I am a principal and consulting actuary with the firm of Milliman. I concentrate on property and liability risks. And while I'm the only presenter here today giving this overview of our report, I should acknowledge Apt Associates, who was our partner in preparing this report, and also the HSCRC, who was instrumental in making sure that the report was clear, and with their appreciation, acknowledge that. Next slide. So the objectives of the report that we prepared were in line with what was requested from the 2020 Joint Chairman's Report. Those objectives were to analyze and compare Maryland's medical professional liability climate with other U.S. states, examine programs in other U.S. states that are used to reduce medical professional liability costs, specifically evaluate what would happen, the impact, if California's Medical Injury Compensation Reform Act, commonly known as MICA, would be implemented in Maryland, and make recommendations on how to stabilize the hospital liability market in Maryland. There is a 115-page report, I believe, that goes over these. This is a 15-slide presentation that I'm going to try to get through in 30 minutes that gives an overview of this. Importantly, I am not advocating for any of these reforms. Our task was to summarize these programs and evaluate and estimate the quantitative impact that would occur if they were to be implemented. The decision to implement any tort reform or other cost reduction program there are many other factors that are outside the scope of our study and outside of my expertise, which is why I don't envy your positions, your jobs here. Finally, the focus of this study was on the hospital liability market, which is different than the physician liability market. And I will go over that in further detail in the next few slides. I'm ready for that next slide, Dylan. Our study utilized various data sources, and of these sources, some of them were publicly available, some of them were not. We surveyed the hospitals in Maryland for closed claim data, and this was performed back in December of 2020. We were satisfied with the response rate that we received based on comparing the hospitals that we received responses from to publicly available data in terms of the utilization in the state of Maryland. Received responses from about approximately 80% of the inpatient days and about 2/3 of the annual deliveries in the state of Maryland. The study concentrated on closed, finalized malpractice claims from 2010 to 2020. Of note, we did not include any open claims in the study, there are many, but in order to eliminate the potential estimation error of what those open claims will close for eventually, they were not considered in the study. For that 10-year period, the hospitals that we did receive data from provided information on about 2,500 claims with about $1.9 billion in lost payments and an additional $235 million of allocated loss adjustment expense payments. Now, when I say loss payments, those are the indemnity amounts that are made to the plaintiff. When I say allocated loss adjustment expense payments, the ALAE, those are the defense costs associated with defending the malpractice lawsuit. In addition to the 2,500 claims with a loss payment, there was an additional 1,700 claims provided that did not have a loss payment, but did incur $61 million of those defense costs. The hospitals also provided information on their retained risk and excess insurance programs, which I'll touch on in further detail in a few slides. In addition, we utilized data from the National Association of Insurance Commissioners, the NAIC, insurance company annual statements, the National Practitioner Data Bank, reports from other state insurance department and patients' compensation funds, and various other industry data sources. Of note, the NAIC data is publicly available. However, it is an incomplete picture of the medical malpractice insurance market. It concentrates on the underlying physician risk, but hospital liability is largely outside of what will be encompassed in NAIC insurance company annual statements. The National Practitioner Data Bank is solely physician claims. When a physician has a loss payment made on their behalf, that loss payment needs to be reported to the National Practitioner Data Bank. That is not the case if the loss payment is made on behalf of a corporation. Dylan, next slide. You can keep going. Thank you. So an overview of medical professional liability, I may also say medical malpractice. These are claims where an underlying patient has had harm, and they allege that that harm was related to negligence from the medical provider. When there is a loss payment made in a medical professional liability claim, that loss payment can be split up into various facets. Of note for this study is the difference between economic payments and non-economic damages. Economic payments, damages, are those that are more easily measurable. For instance, medical payments that are made due to the harm. loss of wages, things of that nature that are more easily measured. Non-economic damages are things that are less easy to measure and more subjective. So they're often called pain and suffering damages. So things, for example, loss of consortium and things of that nature that are worth something, but it's not as easily measurable as what the direct medical and indemnity loss of wages are. The expenses, I touched on that already. The expenses included in our study are those related to defending a claim. These are primarily lawyer fees, legal costs. Expenses not included in our study are expenses, for example, of running an insurance company, and for the hospitals of running a self-insured or retained risk program. Those are not, those kinds of expenses were not considered in the study. Retained versus excess risk. Retained losses are those payments that are made by the defendant themselves. So the defendant does not have insurance for those losses. That is typical of the hospital liability market. These are corporations, and they have a certain number of these claims a year. It's just a fact of doing business, of providing medical care. Due to the number of these claims, they have a somewhat predictable number and amount of payments that they're going to make in a given year. And so instead of buying insurance from the ground up, so from $1, they buy insurance after a particular event gets to a particular size. And the level at which that insurance attaches at, starts to pay, will differ based on various factors from one hospital to the next. It's primarily based on the size of the facility and how much risk they are willing and maybe possible to retain in terms of how much insurance coverage they have. Physician insurance, on the other hand, is typically, or physician liability is typically purchased through an insurance company. And physicians do not typically, individual physicians do not typically retain any costs themselves. They pay the insurance premium. And if there is a claim filed against them, the insurance company will handle the defense. And if there is an indemnity payment on that claim, the insurance company will pay that claim. The limits on the physician insurance are typically provided at $1 million per event. And that often serves as a de facto limit on the amount that an insurance company will pay on behalf of their physician. Hospitals, on the other hand, do not have that de facto limit, and they are essentially uncapped in terms of how much damages could be filed against them. They are considered in many aspects the deep pocket in medical professional liability cases. Next slide. This is a chart that was in our study that shows Maryland having a relative to population, a large number of insurance loss payments in the period from 2010 to 2019. The denominator of these metric is the population per the Census Bureau. The numerator is the total loss payments in that state as reported in NAIC insurance company annual statements. As I mentioned previously, that numerator, the NAIC data, is an incomplete picture. It is an incomplete picture for all of these states, however. And so when we're comparing one state to the next, we think that this is a reasonable measure. The reasons that NAIC data is an incomplete picture, it only includes data reported on statutory NAIC insurance company annual statements. It does not include self-insurance. And so that is the case where a hospital will be paying for some amount of that claim themselves before they have insurance that picks up that claim. And depending on how the insurance company and which insurance companies the hospitals have, it may also not be picking up the information from those insurance companies that are have that excess layer of risks on the hospital risk. Further, there may be other individual state biases within this data. For example, states that have liability funds may be biased low in this comparison due to those liability funds having a share of those lost payments made, and those liability funds not being a regulated insurance company that reports its data to the NAIC. With those caveats aside, this chart shows Maryland as one of the highest states in terms of lost payments to population. Next slide. This slide compares the average indemnity payment, so the lost payment only, excluding the expense amounts, on per claim in Maryland based on the data we received from the hospitals for this study, relative to a Milliman benchmarking database. That Milliman benchmarking database is based on de-identified claim data from our Milliman's client base across the US. So we work with hospitals and we receive their data for studies because as these hospitals are essentially acting as their own insurance company, they need to services such as from an actuary to help them with that retained risk portion. We have that data and we've de-identified it across our clients throughout the US, and that's what represents this blue line. As you can see, the data from the Maryland Hospital Survey indicates that the average size of a claim in Maryland is significantly greater than the average size of the claim throughout the US as measured by that Milliman benchmarking database. Next slide. This slide represents the insurance that is being purchased by the hospitals. Now note that this is a hospital excess insurance, not the ground up physician insurance. And so what this represents is the amount of insurance that the hospital purchases above the amount that they are retaining, that they are paying for themselves. And it's typically on a per event basis. So for example, and a given hospital will likely have multiple insurance partners that assist in filling out what's called their tower of insurance. So as a quick example of this, the hospital, say that the hospital decides and wants to have insurance coverage or coverage for up to $100 million for a given event. What their insurance program may look like is they have $5 million on any given event that they will pay for themselves. They have an insurance company A, that will take the next $20 million of risk. And so if there is a $25 million claim, the hospital would retain 5, insurance company A would retain 20 of the next 20 million. And that will layer on as you get into higher and higher layers. So if that insurance company wants 100 million of coverage and they retain 5, they may have multiple, they would likely almost certainly have multiple insurance partners that would take individual layers of that claim up until they reach their total capacity. Based on the Maryland Hospital Survey data, there have been at least 15 separate insurance groups that have provided this excess insurance coverage in the state of Maryland since 2010. There have been carriers that have exited the market and or carriers that have decreased their writings in this market. But to offset that, there have also been market entrants over this period, and particularly so that the green bar here represents a insurance group that entered the Maryland market per our survey data in 2014, and in 2020 is now the largest provider of excess insurance limits in the state of Maryland. Next slide. So while the prior slide concentrated on the amount of excess insurance that is purchased by the hospitals, the other part of the equation is how much risk does that particular hospital retain themselves? So do they retain 5 million, 1 million, and whatnot? As I mentioned previously, the size of that amount retention, the amount of retained loss will differ from one hospital to the next. And it's correlated maybe quite as you'd expect based on the size of the hospital. So to normalize that, what we've prepared here is a measure of the increase in the amount, relative increase in the amount of retained risk by hospital survey respondent. And we've cut this into the next few slides into year by year tranches. So during the period of 2010 to 2015, there was one hospital that had a 40% increase in their retained risk, while most of the other hospitals did not have an increase in the amount of retained risk per event that they have during the 2010 to 2015 period. Next slide. For the next 5 years, 2015 to 2019, we see a few more of these facilities, of these hospitals and hospital systems that had increases in the amount of retention that they are paying for out of their own pocket versus where that insurance attaches and starts to pay for the claims. This is the period 2015 to 2019. The prior slide was the period 2010 to 2015. And the next slide was the changes between 2019 and 2020. And so in the 1 year period from 2019 to 2020, many of these hospitals and hospital systems had an increase in their retention. So 100% increase, that means that if hospital C, if in 2019, they were paying $1 million per event, or up to $1 million per event before their insurance kicked in. That means that in 2020, they were paying up to $2 million per event before their insurance kicked in. Note that the level of coverage and level of retention for each individual hospital, again, will be different. And that's why this chart was on a relative basis to the starting point of where that hospital was. Next slide. You can keep going. Thank you. So one of the specific scope items that was requested in our study was to evaluate the impact if MICA in California were to be implemented in the state of Maryland. MICA has been in effect in California since it was implemented in 1976. In 1985, it was upheld by the Supreme Court in California. And since then, what this chart shows is the relative growth in premium amounts as reported to the NEIC in California versus the remainder of the US. California is the blue bar here, the US is the black. As you can see, the black continued to significantly increase while California had a more measured increase over these years. The annual average increase from 1976 to 2019 data for California was 2.3%. For the rest of the US was an average increase of 5.1% per year. Next slide. The primary provisions of MICA as they impact medical professional liability cases is a cap on non-economic damages, limits to plaintiff attorney fees, an exception to the collateral source rule, periodic indemnity payments, and a 3-year statute of limitations. Some of these things are in effect in Maryland currently. The cap on non-economic damages in California, and remember, non-economic damages is the pain and suffering portion of the overall damages. This does not impact the amount of indemnification for medical loss, medical payments and loss of wages, et cetera. It's only that non-economic damage piece. That is capped at $250,000 in California. Maryland also has a cap on non-economic damages at $845,000. That cap is increased annually, and there is also a separate, slightly higher cap in a case of a wrongful death with 2 or more beneficiaries. Plaintiff attorney fees in Maryland are unlimited. They are, as I understand, a negotiation with the claimant and the plaintiff attorney. In California, there are caps on the amount of attorney fees. Those caps are based on a sliding scale. And so that sliding scale means that, so it's kind of the way that your taxes are. The first $50,000 of damages awarded, the plaintiff attorney is entitled to 40% of that. The next 50,000 is 33 1/3%. The next 500,000 is 25%. And then subsequent to that, so subsequent to 600,000, the plaintiff attorneys receive 15% of the indemnity amount for fees in medical professional liability cases in California. The collateral source rule is where payments, medical payments, for example, are already made in a potential liability case by another party. In Maryland, where the traditional collateral source rule applies, what that means is that if a private insurer pays for medical costs related to a potential liability case, and they are paying for these up front, they will likely put a lien on those amounts. And what that means is that if that claimant, if that plaintiff, if they ultimately receive money from a liability case, that health insurer, that private health insurer, will get their money back, the amount that they paid for those treatments for that underlying patient. So they have a lien on that judgment amount. In California, there's an exception to the collateral source rules, where private insurers, they do not get their money back, essentially, and those damages are then not argued in California cases. The next two are, and I'm running short on time here, and I'm almost finished. The next two are already consistent between Maryland and California, and so we did not put any additional estimate into those impact of those costs. Next slide. So our analysis, and this is a complex analysis and make up a significant portion of those 115 pages in the report. But as a summary, our estimates of the impact of hospital liability costs in the state of Maryland, for the exception to the collateral source rules, we estimate that would result in a 7% decrease in costs. The decrease in the cap on damages, we estimate to what a MICA provision would be. We estimate that would result in a 13% decrease in damages. And we also expect that if MICA similar rules were enacted, that it would result in a decrease in the number of claims filed. And that is just a simple economic question of, if there are less potential damages to receive, that changes the economics of the question from a plaintiff, potentially, if they will move forward with a lawsuit. And so that is something discussed in the details of the study, and it's something that is empirical evidence in a number of states that have impacted reforms in the past. Next slide. Thank you. So this is my last slide. So the impact of reforms, MICA-style reforms, is broad. Elements of them would impact most medical professional liability cases that currently go through the tort system. If all of the MICA-style reforms were implemented, if you break it down into the specific components, they have more or less impact on an individual basis. Implementation of them would reduce the size of losses. A cap on damages would reduce the size of losses. And we also expect that implementation would reduce the number of claims in Maryland. One note is that MICA style reforms, the actual legislation is important. The details of it are important. And this is discussed further in the report. However, seemingly minor differences in how the legislation is written can have a significant impact in the effectiveness of these kinds of reforms to potentially reduce costs. Birth injury funds, which I did not cover, but on today's presentation, but are covered in the report. Those are a different kind of animal, a different kind of cost reduction program that targets the cases that result in the injuries that result in neurological damages to infants. Those are one of the highest average cost claims. And so birth injury funds, by impacting the sources of those payments for those most significant size of costs, that reduces the variability, the risk that the hospitals take. Overall, there is uncertainty in terms of how these would ultimately impact. We have estimated, if California's MICA were to be implemented and were to stick, and that were to stick point is important. Other states have implemented reforms and have had those reforms overturned, either by judicial or other means. And with that, due to the historical evidence in other states of these things being overturned, we expect that the insurance market would react cautiously in terms of new entrants into the hospital liability excess market and in terms of the amounts that they charge. And finally, going on with that idea, the cost reductions are not guaranteed. While one state to the next, there are significant differences. While it makes sense if you put a cap on damages, for instance, that would reduce the amount of costs. Again, these things would need to play out in the courts in terms of the overall impact. And with that, Chair, I'm finished with my prepared remarks.
All right, thank you very much. We will go to questions here. Members of panel who have questions, please make sure that you raise your hand electronically. I'll call you in the order in which I see you having raised your hand electronically. And we'll start with, from the Health Government Operations Committee, we'll start with Delegates Cullison, then Hill, then Delegate Karen Lewis Young. Then we'll go to Judiciary Committee with Delegate Arakan. So Delegate Cullison, to begin, please.
Thank you very much, Mr. Chair. And Mr. Coca, thank you very much for your extensive report. I have two questions that I think are fairly brief. One is, are we to assume that Maryland has more incidences and claims in terms of the numbers of actual claims, which drives our number up? Or is it the actual, do we have a similar number nationally to the number of claims? It's just the payouts or losses are higher. That's the first question. And the second question is, when you do the calculation comparing what would happen in Maryland if we implemented some of the MICA pieces, did you use the same numbers of California, or did you, consider that just making a change in, for example, a cap on damages would make a 7% change, or was it exactly going back to the 250,000? So thank you. Those are my two questions.
Thank you. So on the first question, the way that I would terminate, the terminology that I would use is the frequency of claims versus the severity of claims.
Okay.
The frequency of claims is not something that we directly measured within the scope of our study. What we did measure is the average severity, the average size of those claims. And that does seem to be the driving force of the higher loss payments in Maryland per capita. On the second question, so our model, what we did is translated the caps based on the hospital survey data that was provided. So translated the caps on this Maryland specific historical closed claim data. And so while we use various data sources, because no single data source has all of the perfect information for us that we needed for a study, and we needed to rely on various external from other states as well, states other than California and Maryland, to estimate some of the parameters for our model. The underlying focus of it was the average size and the curve, if you will, of what Maryland loss payments are.
Okay, great. Thank you very much, sir. Thank you, Mr. Chair.
Thank you, Delegate Hill.
Thank you, Mr. Chair, and thank you for the presentation, Mr. Koga. To what extent are your data, conclusions, and recommendations impacted by the outlier sort of single events like the Levy case settlement for 190 million, which occurred over this time, and how are we to interpret your data if we remove those outliers from the averages in your conclusions?
Yes, so great question. So the significantly large payments and loss sizes that you mentioned, those are typically extremely large due to economic losses. So to pay for, especially in the cases of injured infants, they are to pay for future medical losses and potential loss of wages, things of that nature. The California style reforms do not significantly impact those amounts. What they impact is the non-economic damages. And so when you get to those really significant sized awards, those are largely due to the economic amounts rather than the non-economic amounts.
Thank you.
Thank you, Delegate Karen Lewis-Young.
Thank you, Mr. Chair. As you're aware, the efficacy of the study has been brought into question. So would you be willing to say a few words about the methodology for the study design and the data collection effort?
I'm sorry, I'm not real familiar with what you're talking about the study being called into question.
Well, it was part of our backup. Maybe you haven't seen it. Apparently in 2020, a study was contracted with App Associates and your organization for an independent analysis. And this study is being questioned. The methodology is being questioned. So I'm fairly familiar with that. I know they always start out their findings with a review of methodology for both design and data collection. Maybe you're not the right person to answer that question, but because this theme is fairly prominent in our backup reading, I am interested in the methodology.
Sure. So I'm not familiar with any direct questions on the methodology utilized in our report. We utilize data from Maryland hospitals directly and also publicly available insurance company data. As discussed in the presentation, there is not a source that is publicly available data for hospital liability insurance payments. And that's why we needed to go directly to the hospitals and survey them for that data. The NAIC insurance company data and the NPDB data, those are primarily based on and data from the physician insurance market as opposed to the hospital liability insurance market.
Thank you.
Thank you.
Delegate Erican, then Senator Kramer.
Thanks for being here. So hopping back to the Milliman client database, I'm just wondering sort of who are the hospitals involved? How many are there? Were there many in Maryland? Where is that data coming from?
Sure. So that database, we removed the Maryland hospitals from the data that we did have on hand from that database in terms of having a Maryland versus non-Maryland comparison. But that is from our client base across hospitals in the US. I don't have the number offhand in terms of how many claims are in that database, but it is significantly larger than the data that we received for the Maryland specific data for this study.
So are we looking at like 50 hospital systems or 20 or 150? I mean, do you have any ballpark for what this data is actually, where it's actually coming from? So we sort of have a scope idea?
Sure. And I note that there's a difference between a hospital system, which could include, the largest ones are hundreds of individual facilities versus a small community hospital. And it includes both systems and those individual hospitals. If we think about, breaking down those systems into individual hospitals, I would expect, based on just the overall number of claims, that it would probably be close to 200 to 250 hospitals included in that database.
Okay, and then did you do any analysis to sort of see, let's say we had the $250,000 cap, what would the last year have looked like in Maryland?
That retrospective kind of analysis was not part of what we were attempted to do. We were, looking forward in terms of what the future costs would be.
Very much. Thank you, Mr. Chairman.
Senator Kramer, then Senator Hedelman, then Delegate Conaway.
Thank you for that, Mr. Chair. Mr. Milliman, if I can, I just want to revisit quickly that good question from Delegate Cullison about the differentiation between, the Maryland payments and that on the national level with regard to the frequency of litigation versus, maybe higher claims payments. And would some of those higher claims payments drive the frequency of litigation in Maryland, which I think would be important for us to have a better understanding of, what the motivating factors may be. And so that we do experience possibly greater frequency of claims based on the higher outcomes of those claims. Without that kind of information, I'm not sure that comparison is useful in our discussion of this subject. And then that also leads to the next question of, did you all look at the outcomes of those claims by jurisdiction within the state? Because I know that very often the litigation is driven by the jurisdiction in which the case will be heard, and that there may be higher payouts, and that's very often what attorneys look at when making those decisions. Was there any discussion of that at all in your research?
Thank you for that. So taking the latter question first, there was not a specific review of the different areas and different court systems within the state of Maryland. It concentrated on the state as a whole. There was a letter that one of the hospital survey respondents provided from one of their excess insurance carrier partners that discussed Baltimore City and County specifically, and that carrier was planning to avoid specifically Baltimore City and County. But our analysis concentrated on Maryland statewide, not the various jurisdictions within the state. On the question of the frequency of claims, so we do estimate that, and the likelihood of a claim being filed tied with the average size of the claim. That was not something that we measured specifically with the Maryland data. However, there is clear evidence in other states that have implemented these types of reforms where they implement a reform that is intended to reduce the average size of a loss. And subsequent to implementing that reform, the number of claims in that state significantly decreases. There is a chart in the study that I believe specifically discusses the state of Texas that implemented reforms in the early 2000s and what happened in that state as it related to just the number of claims filed.
So there is a clear correlation. Is it possible for you to provide the committee chairs at the very least to then disseminate information on what research you may have in that regard?
Yes, so that it is included within the report.
Great, thank you for that. Thank you, Mr. Chair.
Thank you, Senator Hedelman, then Delegates Conaway and Fisher. Senator Hedelman.
Thank you very much, Mr. Chair. I found quite dramatic your tranching of the years into five-year segments and the increase. And can you just, in your opinion, I mean, what factors are most relevant leading to this increase in claims and frequency?
Sure. So there is a hard market in terms of the excess liability throughout the U.S. right now. And when I say hard market, that means that the insurance companies, they want to either receive more premium for the liability protection they provide, or they want to provide less of that protection for the same amount of premium. So in other words, they want to, instead of attaching at $1 million, they want to attach at $2 million and whatnot. There may be various factors that go into those decisions for a given insurance company, and that's driven by the risk of having a significant payment in those venues, though.
And if I could ask a follow-up to that. So it's a change in insurance companies' behavior rather than any particular policy changes that we have made over that period of time.
It is a reaction of the insurance companies to the underlying amount of payments that they are making in that venue. So I believe the answer to your question is yes, I agree with that.
Thank you. Thank you, Mr. Chairman.
Thank you very much. We'll go now to Delegate Conaway, then Delegate Fisher, and then I think that's going to end the questions for this first panel. Delegate Conaway.
Thank you, Mr. Chairman. My question goes back to something Delegate Hill was touching upon. As I understand it, the graphs were broken down to show future economic damages and also what you just called damages, but I'm going to say current real damages. Were these two figures commingled on the charts together?
For the charts that show the overall average severity,
Yes.
Those amounts reflect both non-economic and economic damages, which are combined, considered what the lost payments are.
But some of the raw data that you used was just the economic damages. Is that correct?
The claim data that was provided by the hospitals generally showed the overall loss payment that was made, and it did not reflect what portion of that payment it was for economic damages versus non-economic damages. That detail is not typically held in claims databases, and it's not. And it's the reason for that. It's not always 100% clear. The vast majority of medical professional liability cases end up in a settlement, not in a jury verdict. And so, they concentrate on having, that overall number that they're paying out. As the individual case filer getting worked up, yes, they are separating those damages. But typically what enters into the claim database that we received as part of our survey is the overall loss payment, not separated between the economic piece and the non-economic piece.
Thank you very much.
Thank you. And last, Delegate Fisher, please. Delegate Juanita Fisher.
Thank you, Mr. Chair. I don't know if this is the correct question for you, for potentially another panelist, but the birth rates during the pandemic have been significantly decreased across the country. And I was just wondering how you all are looking at that with the numbers when it comes to Maryland, and do you expect it to re-normalize, and that will affect your opinion on, or your perspective on how much birth injury you'll be facing? Or is, there are different people out there that are saying it's going to be on a decline for a while due to the pandemic. And so just wanted to get some feedback from you on that.
Yes, I do not have, I have heard data from my colleagues in terms of that could inform that, but I do not personally have any specific opinion on how the pandemic has influenced that. The pandemic has had a multitude of ancillary impacts on obviously our everyday lives, but also impacting the medical healthcare delivery and medical professional liability. Our study was based on data through year-end 2019 in terms of the publicly available data that we had because of when it was performed. The insurance industry in general, if you look at just the amount of payments in 2020, they were significantly reduced. And so if you look at just that 1 year, you would expect that 2020 payments were so low. However, they were low because the courts were closed for half of the year. And those payments are likely still to be made in the future. It's just that they've been delayed. And so, and when you're looking at long-term patterns, you have to have an understanding of what are the impacts looking at each individual year versus looking at longer-term patterns of that. And so the ancillary impacts of the pandemic, is something that I think will be studied for decades and after this in terms of impacts on various things throughout our everyday lives.
Okay, we thank you very much, Mr. Koka, for your presentation, for answering questions here today. We thank you very much, and we're going to go now to the first of two panels. This first panel will be a panel representing the Maryland Hospital Association. We welcome Brian Frazee, the Vice President of Government Affairs for MHA, Tori Bayless, the CEO of Luminous Health, and Dr. Stephen Evans, the Executive Vice President of Medical Affairs and the Chief Medical Officer at MedStar Health. This panel is going to have 30 minutes to present their remarks, and then we'll take questions from committee members. And we'd ask the questions again are going to be related just to what this panel is going to be speaking about. We're not going to be able to go back and bring back Mr. Coca. So you've got to direct your questions at this panel. The time on my phone here is 2:01. So we're going to give you till 2:31. Mr. Frazee, I understand you have a PowerPoint.
Yes, I actually a one-pager, Mr. Chairman.
That's fine.
Great. Thank you very much, and good afternoon, Chairs Klippinger, Smith, Pendergrass, Kelly, and Resnick, as well as all of the members of the committees here today. For the record, my name is Brian Frazee, and I'm the Vice President of Government Affairs for the Maryland Hospital Association. As you know, MHA represents all of Maryland's nonprofit acute care hospitals and the nearly 120,000 healthcare heroes they employ. I want to thank you all for making the time for this important briefing on the status of Maryland's medical liability climate. For several years, you all have heard us talk about the challenges hospitals are facing on this issue. We've introduced bills, offered compromises, submitted data, and sought common ground to identify a reasonable solution that balances the need to ensure that plaintiffs and their families get what they deserve when something does go wrong at a hospital, with the very real need to stabilize a liability market that is among the worst in the country. Let me take this opportunity to again make clear that the market we are addressing in today's conversation, and that MHA has continued to put in legislation to help stabilize, is the hospital self-insurance excess market. This is different than the physician malpractice market that is represented by companies like MedMutual and provides $1 million policies to cover individual physicians. I will note as well that the Maryland Insurance Administration regulates the individual physician market, which again is separate and apart from the hospital market that is the subject of this report and our testimony today. You just heard about the very real challenges with our system from an independent actuarial firm that spent months studying our market. The report that Mr. Coca just walked through confirms that our system is broken and that meaningful legislative action is necessary to not only preserve, but to expand access to critically important services in our state. You just heard that hospitals are experiencing higher risk retentions, rising premiums, as well as more restrictive coverage terms. Additionally, you heard that the report says that the market in Maryland is among the worst in the country, that we are among the states with the highest losses paid by insurers, on average 75% larger in Maryland than the rest of the country, that overall insurance coverage in Maryland decreased between 2010 and 2020 because there were not enough excess insurers willing to write policies. And finally, that insurers are leaving the market altogether, or as the report cites, one large insurer has declined all new business from Baltimore City and County. This is a distinction that has only been reached by Chicago, New York City, and Philadelphia. And I will note that Milliman's findings are consistent with Aon, another actuarial firm, which has been publishing reports on hospital liability data for over 20 years. Their findings over the past 3 years in particular support Milliman's report that Maryland has a challenging insurance climate. Going back to Delegate Cullison's question earlier of the previous panel, Aon actually did look at frequency of claims. They found that Maryland's frequency of claims is half of that of the nation, and yet our severity or payouts were double the national average, meaning that this is not a quality issue, it's a hospital liability climate problem. We are here to talk to you today about what this worsening climate means for hospitals and care delivery in the communities that you all represent. You will first hear from Dr. Steve Evans, who serves as Executive Vice President of Medical Affairs and Chief Medical Officer of MedStar Health, followed by Tori Bayless, Chief Executive Officer of Luminous Health and a member of the Health Services Cost Review Commission. You'll hear about each of their reinsurance renewal experiences, the impact on access to care, as well as efforts that are underway both locally and statewide to ensure quality and equity in the delivery of hospital care in Maryland. And most importantly, you're going to hear about our hospital's commitment to patient care. Our hospital heroes have cared for Maryland through every COVID surge over the past 700 days. They've saved thousands of lives, and sadly, during this latest surge, are seeing some of the darkest days of this pandemic. And while we are not here this afternoon to talk about specific legislation, I did want to acknowledge the potential solutions that are outlined in this report. We are committed to continuing having a pragmatic approach toward addressing this problem, and we look forward to working with these committees and the Maryland Association for Justice, with whom we have spoken to and are meeting with again next week, on a reasonable solution that again stabilizes our market while ensuring that patients and their families get what they deserve. Thank you.
All right, whoever would like to go next.
Thank you, Brian, and thank you, committee chairs and members of the Maryland Senate and House, and all the committee members present today for this time. The issue of medical negligence and malpractice is a very real issue in the state of Maryland, as it is across the country. The approach that the Maryland hospitals have taken, including MedStar Health, has been a simple and straightforward one for many, many years. Open transparency and honest discussion with patients and their families who have been injured, in injuries that have occurred that are preventable. Secondly, what we do to prevent that injury in the future so it never happens again. Also being really important that we support them with continued excellent medical care, financial support, and any other support required to keep them whole. It's critically important, so important in fact, that to the Maryland House in 2017, we submitted legislation called CANDOR, C-A-N-D-O-R, Communication and Optimal Resolution, that was focused specifically on the thing that I just outlined, that really is an important and critical initiative. And in fact, the Agency for Health Research and Quality, AHRQ, government agency, promoted it and sponsored it as one of the best programs in the country and has endorsed it to be used by other healthcare systems around the country. The issue that's been outlined in the Milliman report related to how we as hospitals and healthcare systems insure ourselves is important. Mr. Koka gave you a good example of how we build what we characterize as the tower, the number of excess insurers that are put in place. So let me give you an example. If we build a $100 million tower, we have multiple insurers that will actually go beyond what our original deductible was. So for instance, for MedStar Health, if our original deductible was 10 million, then we would actually be purchasing another excess carrier for the next 10 million and then 25 million to go well beyond the 100 million that we currently have in place. What has happened, however, in the last few years is several things have changed this equation. To build a tower, it's become much, much more difficult. The cost to build the tower for us now has gone up 20% in the last year, for over $1 million additional dollars to build the tower. In addition to that, beyond the point of the deductible, our deductible has increased by 10 million, from 10 million to almost 20 million in a period of 18 months. Our experience is not dissimilar from what we're seeing around the rest of the state of Maryland and in highly impacted states such as you've seen, New York, Connecticut, and Rhode Island. In addition to that, it's harder and harder to find insurers that want to be the next excess carrier above our deductible. And most importantly, the actual carriers that are coming in are putting significant restrictions on what is actually covered. So no restrictions for COVID cases, no restrictions for cyber, and restrictions around obstetrical cases that are really well defined, making it harder and harder to build out that specific tower that we've talked about. I'll give you an example. Mr. Koka mentioned some of the actual excess carriers that have exited the Maryland market. Zurich, one of the biggest excess carriers in our region, exited the Maryland market in 2018, citing the toxic environment. In 2019, Swiss Re, one of the biggest excess carriers, also exited, stating specifically, only way we would do it is for a 25 million as the prime for the deduction, nothing above that. Munich Re exited in 2020 for the exact same reasons. And most recently, CNA, one of the largest excess carriers in the country, exited as well, specifically related to all the issues that we've just outlined. All of this characterizes a harder and harder market for us to build the tower on increasing dollars. And I'll give you a sense, two simple cases at a 10 million deductible, $20 million and a tight margin for a hospital. Those are all dollars that we would be using to increase care to our underprivileged, underserved, and to build out really great clinical models of care within the state of Maryland. Let me shift to just two other areas that I think are really critically important. The impact to access of care. If we use a hospital like MedStar Harbor Hospital that sits in the Cherry Hill district, many of the patients, individuals there are either underinsured or uninsured. Our obstetrical services there have been critical to that community for many, many years. But as you've heard around obstetrical services, these kinds of services make it difficult and harder in terms of protecting these services for our communities because of these really, really high costs for individual malpractice claims. The individual frequency of the claims has gone down as a reflection of the quality and safety within our state, but the overriding runaway juries have made this really, really difficult in terms of managing this. The last piece I would mention is around quality and safety. And this is a critically important piece within the state of Maryland. Within the last couple of days, the HDO committee has heard an outline from the HSCRC just how well the state of Maryland is doing in quality and safety. In fact, CMS uses this as a role model, thinks that we're doing an incredible job. Do we have more work to do? Yes, we do. But we're on an incredibly good path that seems to show great quality and safety within the state. The actual number of claims appears to be down. This is one specific issue looking related to the size of the individual claims. And when we look at MedStar Health, the actual increase, the amount that we're paying out per year, which has gone up every year, is solely related to the claims above $1 million, not the smaller claims. What I would also tell you is we're not looking for a complete redo on this. What we're looking for is stabilization of an unstable medical practice liability market. It is so unstable that it concerns all of us as it relates to how we provide care and how we deliver it on a daily basis. I think what we all want at the end of the day is the best care for all of our Marylanders. But these kinds of prices and the instability and the actual exodus of these kinds of insurers makes it harder and harder to carry out this task. So with that, I'll turn it over to Tori Bayless.
Thank you very much, Dr. Evans, and thank you, Mr. Chairman, all the chairs and the members of the House and Senate committees for the opportunity to share some of our experience with you today. So I'm Tori Bayless. I have the privilege of serving as the CEO of Luminous Health, which is a multi-hospital system in Maryland, serving Prince George's County, Anne Arundel County, parts of Southern Maryland, and the Midshore region. And I wanted to pick up on some of Dr. Evans' comments about quality. When we think about the measurement and how often the state of Maryland is compared to the rest of the nation, whether that's through our regulator, the HSCRC, or other programs that we see, Maryland performs quite well and has been on an upward trajectory on numerous different quality scores. So if you think about broadly issues around sepsis or infections, and then more specifically around quality programs related to obstetrical care and maternal and infant health, Maryland is moving in a very positive direction. The March of Dimes recognized the state of Maryland as the first state in the country where all of its birthing hospitals were able to reach a threshold of safety and quality related to premature births or early deliveries, early elective deliveries. So there are a number of metrics. We also look at organizations such as Leapfrog or the Magnet organization. And across the state of Maryland, almost 20% of our hospitals have a Magnet designation compared to the rest of the country at less than 10%. Leapfrog, which is an organization representing the purchasers of healthcare across the nation, also evaluate hospitals. And over the past 4 years, the state of Maryland has seen dramatic improvement in the number of A-rated hospitals, where 4 years ago we were trailing the nation. And now, on average, the hospitals are 7% better in those quality metrics. And just as two examples, Magnet and Leapfrog are really stringent frameworks that evaluate hospitals on quality, patient safety, patient experience, and cost structures. As Dr. Evans mentioned, the HSCRC had the opportunity to share some data yesterday. I won't repeat that other than to say Executive Director Katie Wunderlich and Chairman Kane are in regular conversations with the federal government, and CMS and CMMI do hold Maryland out as a model, and that's relative to infection rates, rehospitalizations. And I would say more broadly, the state of Maryland operating under this model with the federal government has significant focus on what we call the SIHIS goals, the State Health Improvement Plan. And those efforts are very much focused on behavioral health, opioid use, and diabetes, as well as maternal and child health. So there really is a concerted effort around the state for all of the hospitals to partner with other stakeholder groups to continue to move along this trajectory of improving care, quality, outcomes, as well as reducing disparities. And of course, you can't have quality without equity. And that's a significant emphasis as well through the HSCRC and all of our hospitals across the state. Specifically within Luminous Health, we have a number of initiatives relative to obstetric care. And I say that because one of our hospitals here in Annapolis is the second largest birthing hospital in the state of Maryland. And while we have seen birth rates declining nationally, we've actually seen an increase, and we deliver about 5,600 babies. And we say that's about a kindergarten class a day here in Annapolis. But we've had a number of efforts underway through our obstetrical leadership, our physicians, on strict adherence to evidence-based protocols through the American College of Obstetrics and Gynecology, whether that's related to hypertension or maternal hemorrhaging, the use of doulas, reducing our C-section rates, preterm deliveries, and improving breastfeeding among mothers. We've also had a very specific emphasis, and this is well supported by the Maryland Hospital Association broadly, on health equity. At Luminous Health, we've had a health equity and anti-racism task force. We call that the Heart Force. And this really does measure disparities, and so that we can be really intentional about our interventions. Dr. Evans mentioned access, and this is a real concern that we have. We know that a number of obstetrical programs have either closed, relocated, or downsized over the years. Specifically in Prince George's County, Luminous Health is looking to add and expand obstetrical care for women in Prince George's County, where today 8 out of 10 women leave the county, have to travel outside of Prince George's County to get obstetrical care. And as we're committed to adding additional services, I will say that the liability climate makes this new program very challenging because of the projected losses coupled with this significant liability exposure and the imbalance in our liability market right now. You heard the Aon statistic about half as many claims, but twice the severity. So it's a bit of a mismatch in our minds when you think about the quality performance and the trajectory we've been on, that we find ourselves in one of the worst situations of all the states in the country relative to medical malpractice. With regard to our insurance program at Luminous Health, very similar to what Dr. Evans described, and we know this is the case for all of the hospital systems throughout Maryland. We're self-insured, where we provide the first layer of coverage. Think of that as our deductible. And this means that, we've gone from $2 million to $5 million, and we're facing another increase in the next year. That's for every claim paid. In terms of our excess insurance, filling that tower, if you will, we used to have an aggregate of 30 million. We've had to raise that up to $75 million because of the nature of the market. In terms of our premiums, we have to obviously purchase this excess insurance, and we have seen massive increases over the past 4 years in purchasing those excess insurance layers. In fact, even in just a year from 2020 to what we saw in 2021, we saw a 46.5% increase in the total cost of our liability coverage. So those are significant dollars. They come off of our bottom line. They come off of our community benefit investments. They're not therefore available to invest in the kind of programs that we want to invest in. So we've certainly been advised, again, many reinsurers have left the market. Dr. Evans detailed that well. We've also been advised that our retention limits will be increasing significantly this next year as we talk to the excess market. And so we're obviously very concerned about this. We're routinely advised by the insurance companies of how unfavorable a market Maryland is, and our ability, again, to invest in clinical programs, whether it's behavioral health, obstetrical services, diabetes reduction. These claims that are paid out in excess of what you see around the rest of the country, those dollars are then not necessarily available for these kinds of programmatic investments that we want to be able to make. So again, we're not looking to undo this. We've recognized that patients and families need to have recourse if there's been harm or preventable medical errors. But really, this issue of tort reform is a balancing act to ensure that individuals harmed have access to recourse, and that the recourse, that it doesn't undermine or destabilize our healthcare system and the public's access to healthcare. So the current system, again, rewards the few 3% of total claims filed with these massive payouts of 28% of the total losses. And we certainly will support a system that focuses on the patients and their families and getting them what they need. We just don't want to be doing that in a way that cripples our healthcare infrastructure. So thank you, Mr. Chairman, for the time. And I will just maybe turn it back to our colleague, Brian Frazee at the Maryland Hospital Association for any additional comments.
Sure, thanks, Roy. And I think with that, Mr. Chairman, our panel has concluded our remarks. Happy to take questions.
All right, thank you very much. There are several, and we'll start with, from the Judiciary Committee, Delegate Deborah Davis. Then we will go to Delegate Cham, Kipke, Valentino Smith, McComas, Krebs. So Delegate Davis, please.
Thank you, Mr. Chair. I am concerned that that there seems to be a conclusion that that we have a problem in the state of Maryland, and we all seem to be pointing to the insurance companies, but yet they're not here. What is it? Is there someone who's willing to speak to the insurance companies, the secondary insurers leaving the state, and because of their profit margin? Do we know that it's an unfriendly profit margin for them? And we talk about the toxic environment in Maryland, and I haven't heard anything about the maternal mortality rate in the state of Maryland that exceeds some third world countries. So I'd like to go to other solutions and other factors that have to do with these numbers.
So I could maybe make a couple of comments if I could. Thank you, Delegate Davis, for the question. So I would say it's important to distinguish that the hospitals and healthcare systems, we actually are the insurance companies because we're self-insured for millions of dollars before the excess carriers kick in. And then it's our premium costs related to those. So we think of the insurance market as two tiers or two levels. We are the insurance companies and we're paying those claims up to a significant level, and then the reinsurers kick in if they're willing to still even be in the state of Maryland. So I think of it in that way. And you're right, we don't have the insurers here in the room with us, but they are exiting because of the magnitude, the size of these some really enormous claims, making Maryland a very unfavorable market for them to do business in. So they leave. With regard to maternal morbidity and mortality, this is a significant area of emphasis. Again, we look at the measurements and we look at the disparities. And as recently as 3 days ago, meeting with the Maryland Hospital Association, a commitment through the board to have even further concerted efforts. I mentioned a number of the activities already underway with the centering programs, the doula programs, the programs. Additionally, we have the Maryland Moms program, the Be More for Babies. So really having a more concerted effort to make sure that we're all adhering to those guidelines, and even looking at the state of California and other states that are performing better than Maryland. We as a country don't do well in this area, and that we as Maryland, we do better than the average in the country, but the average isn't good enough. And we're looking at other states such as California and some of the methods that they've put in place to reduce maternal morbidity and mortality.
Thank you. We'll go to now give the full lineup again. Delegate Cham, followed by Kipke, Valentino Smith, McComas, Krebs, Sobbs, and then Senator West. Delegate Cham.
Thank you, Chair. I think Ms. Bayless was actually getting to my question, answering my question regarding what are we doing to further support women of color, Black women who are dying, delivering a baby. What other solutions can we do? Where are we missing the mark in that? So you mentioned the programs that you have in place. I don't know if there is more that can be done, but I'm appreciative of what Ms. Bayless sort of wrapped up at the end of her comments. Thank you.
Well, Delegate Cham, if I can also just jump in. So I think what we've relied on is each individual hospital or healthcare system developing their programs for maternal and infant medical problems and issues. And we need a broader statewide problem. MedStar Health, similar to what Luminous does, we have a Safe Baby, Safe Moms program that's full wraparound services from the time of actually thinking about conception to 3 years after birth, focused heavily around Prince George's County as well. and really focused heavily on underserved communities. Those programs have been successful, but we really do need a statewide program that elevates all of the hospitals and healthcare systems. And I hope you're feeling sort of what the passion is around this and recognizing we clearly have more work to do, but we're also deeply passionate about the kind of progress that we can make.
Delegate Valentino, I'm sorry, Delegate Kipke, then Delegate Valentino Smith.
Thank you, Mr. Chairman. My question's for Mr. Frazee. Where do you think we go from here?
Thanks, Delegate Kipke. So, well, let me start answering that by saying that, as I mentioned in my remarks, we have introduced legislation for several years, various iterations of legislation. We had a version of a birth injury fund bill for 7 sessions. We introduced a bill around life care planning for 2. Last year, we had a bill aimed at protecting our healthcare heroes during the pandemic. And now we have an independent actuarial report on these challenges. And we appreciate that the House chairs have committed to convening a work group of experts that can come together and identify a reasonable and meaningful solution to this problem. We hope the Senate will have a role in that as well. And we look forward to participating in that in good faith and moving that forward.
Thank you. Thank you, Mr. Chairman.
Delegate Valentino Smith.
Thank you, Mr. Chairman. Good afternoon to the respective members of the House and Senate. So for Mr. Frazee, a couple of delegates have tried to hone in on this, and I just still am struggling. So we took a report that said on slides 6, 7, and 8 that in Maryland we have 75% greater amount of claims. And then Milliman told us that their report wasn't based, I think Delegate Cullison asked this, but frequency of claims was not measured in the Milliman report, only the average severity of the claim. So we have breaches in the standard of care that are being found to result in significant and aggressive findings of loss. So the severity in Maryland is greater, according to Milliman, not the frequency. And Mr. Frazee, you came up and said we should not be as concerned because in Maryland, the frequency is less. So that still means we have breaches in the standard of care that are severe. The actual finding, someone has to find a breach in the standard of care in order for such a large award to be awarded, correct? So we have, according to the nation, the types of breaches that we're seeing and the types of damages are more severe because in California, economic damages were not limited, only non-economic. So I guess my question is Maryland having more severe breaches in the standard of care with a population of people? And is this about birth injuries for a population of people that are having significant damages and we're just trying to limit their ability to get non-economic damages? Is that what is driving the insurance carriers away?
Thanks, Delegate Valentino Smith. So first, let me make clear that we believe very strongly that when something does go wrong in a hospital, patients and their families should get the compensation that they need and deserve. And I do want to clarify that we do agree with the report both that Milliman has and the Aon report that I mentioned and other actuarial studies that have been done, that we do have a frequency of severity problem, not this frequency of claims problem. And it is true that the frequency of claims around the country is down, and that includes Maryland. And we believe that that's in part due to the efforts by healthcare systems to reduce the incidence of preventable harm. And so our concern is really not about the frequency of claims, but the frequency of the severe claims that we're seeing, because that's really what's driving the reinsurance challenges that are outlined in the report.
So I could add to that, Delegate Valentino Smith. I think what I'm hearing you say is the severity of the cases in terms of the dollar amounts. Is it reflecting more severe injury or harm in the state of Maryland relative to other states? And we see a number of other publicly available databases that show the clinical outcomes and clinical experience of Maryland being, relative to other states. And it is not showing Maryland as having, worse clinical outcomes. In fact, in numerous instances, they're actually better than other states. So it depends on what type of injury we're talking about, whether it's a surgical injury, a birth-related injury, clinical judgment-related harm. There's a number of different ways we can compare, but when we're talking about the severity, it's really the dollar amounts, not necessarily the severity of the injury or harm to the patient themselves. So I think it's an important distinction between the dollars and the clinical injuries and outcome. And I'm not sure if Dr. Evans might elaborate on that from his experience as well. But there are a number of data sets we work with to understand our clinical experience. And we have the state of Maryland under the scrutiny of the federal government because of our waiver system here, our model, where we're routinely compared to the nation on a number of quality and safety indicators, where Maryland is actually performing better. So I'm not sure if that was your question. I may have been hearing it a little differently.
I'm afraid to risk a second bite at the apple, but that would mean that the severity of the claims, if it's the same nationwide, creating the appearance that lawyers or practitioners in this area are just collecting higher amounts of non-economic damages. I don't know. All right, thank you.
Delegate McComas, then Krebs, Saab, Senator West, Delegate Conaway.
Thank you, Mr. Chair. I guess I'd kind of like to go back to the beginning. We do not have a medical court, is that correct? In other words, that just hears medical malpractice cases. I mean, there's the health claims arbitration, but that's just kind of a pass-through, right?
That is correct.
Okay, so we don't have trained judges in medical practice, and we certainly don't have jurors that are trained in medical practice, right? In other words, it's whoever the lawyers on either side pick the jury. They could be laborers or they could be PhDs in physics, whoever they think is going to be good, right?
That is correct, Delegate McComas.
Okay, so do you think if we had a more specialized court that would help the situation? Because a lot of it is causation. Quite honestly, medicine is part art and part science. And, if someone explains the issues and has a good case and you have a very compelling victim, it seems to me that she can really tip the scales. And I don't know if the judges are using remediator in these cases or not, but I guess I guess what I'm trying to understand is some of the problem just the mechanism that we use to decide malpractice cases. And I know this is beyond the scope of the study, but at the end of the line, that's what's raising, all these judgments that are very, very high. That's part of the problem. That there wouldn't be a problem for excess insurance if you didn't have that problem. That the juries are coming up with very, very high damage awards. So if somebody could comment on that or just say, hey, I'm off base, that's okay too.
Delegate McComas, I think you're not off base. And so let me start, and then maybe Tori Bayless and also Brian can jump in. I think we trust implicitly the judgment of our Marylanders in the jury system. And I think around the country, that process has been used. And I think we trust it implicitly. I think the challenge has been around life care plans that the plaintiffs' attorneys have utilized, which have been extreme and excessive. And I think that gets back then to the original question. These cases aren't of greater severity based upon really good benchmarking we've got from around the country. It's around the severity of the economic damages that are attached to these cases. And so if there was management around how we did life care plans, that would be a good piece. I think there's additional things that can be done beyond tort reform that get into the area of court reform related to the judges. That's not within scope. It certainly would be an interesting thing for us to look at. But I think the issues that you raised are important ones.
Yeah, and if I could jump in here too, Mr. Chairman, I would just say that we think all options should be on the table. As I explained earlier, we have put different options forward over the past few years, and we're committed to putting experts around a table to find a reasonable solution for our state.
Delegate Krebs, please.
Thank you, Mr. Chair. This is my 20th year, and in my very first year here, we talked about medical malpractice and the exodus of OBGYNs from the industry, and it was a crisis. I think we even had a special session on it. I see it seems like we solved a little bit of the problem for physicians, but they all migrated to the hospital systems, and now the hospital systems are in a crisis with this. But my question, we had a briefing yesterday in HGO on the total cost of care, which is our unique model here in the state of Maryland. And I know it's a big benefit to us how we have this model, but what is the potential risk? I mean, I don't know how this flows through into the total cost of care model, but what is the risk of that and influencing our rate what could it impact with our rate setting?
I'll turn to Tori to answer that question.
Thanks, Brian. And thank you, Delegate Krebs, for the question. So I think that the medical malpractice market here in Maryland, it is destabilizing hospitals' finances in a way that then prevents us from making investments in what our model calls for. So the model is calling for significant investments, not just in hospital-based care, but care outside the walls, care in the community, population health-based investments. So if you think about the economics for Luminous Health, if we have 3, 4, 5 claims that we have to pay out over the course of a year, and let's say they're $5 million each. So that's coming out of Luminous's Health's operating dollars. That's $25 million we don't then have to make other investments under the model. So when we need to perform well from a quality and a cost structure, there's a destabilization in how we can make those investments. And then just the financial stability of hospitals is important. We see hospitals with operating margins typically in the 2 to 3% range, considered, strong. And those dollars are then, of course, reinvested in the communities that we're serving. All of the hospitals and health systems in Maryland are nonprofit charitable organizations. So all of those dollars are reinvested in the community. So if we really think about this medical malpractice market as financially destabilizing and taking dollars that could be paid and invested in other ways, whether again in behavioral health, obstetrical care, improving access, decreasing disparities, we're called upon to make those investments. In fact, we're driven to make them by our mission, and it marries up to the model as well.
Thank you very much.
Senator West, then Delegates Conway, Arakan, and Delegate Robin Lewis. Senator West, please.
Thank you, Mr. Chair. It's great to see my former HGO colleagues on this call. So my question is for Dr. Evans. Dr. Evans, I didn't scribble the information down quickly enough, but when in your testimony, you talked about major insurance companies, which almost on an annual basis had been leaving the state of Maryland. I did manage to copy down Zurich and CNA. There are a couple of other major ones that I did copy down. But so my question to you is, undoubtedly, when one of these major companies leaves and your tower is diminished by several floors because that company is no longer available to provide reinsurance, you've had conversations with the insurance companies. Why do they tell you they're leaving? The Maryland Association of Justice suggests that these companies have never been more profitable. So under the circumstances, what is their excuse for leaving the state of Maryland?
So thank you, Senator West. It's uniformly the same for all of the companies that exit. It's simply a too costly and too unstable medical liability environment. And so from their perspective, even companies such as Beasley, who sit in place, who've been with us for many years, their losses continue to mount up in terms of what we pay in. And so even companies that we're able to build our tower. So our year runs from January 1st. Senator, we built our tower at 12:40 p.m. on December 31st. We literally had to scramble to get the last companies in. We were able to do it, but it gets harder and harder every year. So uniformly the same reason, same rationale, the cost, the risk, and the size of the actual awards that are in place puts them at risk, almost independent from where they sit within the stack or within the tower. So it's been a uniform concern.
Thank you.
Thank you. Delegate Conaway.
Thank you, Mr. Chairman. To Ms. Bayless, you said that the hospitals are self-insured, and I want to know, are they insured as generally? Are they self-insured as a subsidy company of the main hospital, or as a separate company that is owned by the hospital, or its board of directors?
Thank you for the question, Delegate Conaway. So at Luminous Health, we have an insurance company that is a separate company, but under the parent of Luminous Health. So it is our own insurance, and we pay the premiums for excess, and we fund the first dollar and pay all the deductibles for the claim. So we are insured through that company, and it has a board of directors, but it is ultimately accountable to the Luminous Health parent for that insurance. I think that's a fairly typical model for self-funded. I can't speak to each system around the state. Dr. Evans could probably speak to MedStar's structure, but that's a fairly typical model here in Maryland for self-insurance, as well as nationally for hospitals and health systems.
Do you insure other hospitals that are not in your network?
We do not. Our insurance company within Luminous Health exists to insure our hospitals and our employees and affiliated employed physicians who are under that umbrella.
Thank you very much.
Thank you.
Delegate Arakan, then Delegate Robin Lewis, and then we will move to the next panel. Delegate Arakan.
Thank you, Mr. Chairman. Thank you guys for being here. My question, I think that Mrs. Bayless touched on this. She mentioned that the sort of 2 to 3% margin because everyone is required to be nonprofit. What do you think might be a more fair margin? How can Maryland make this system more fair? Is 2 and 3% not enough? Is 4% better? What would you say is a more fair margin?
So thank you for the question. It's not that there's an ideal margin. Hospitals are making investments and subsidizing certain losses, and there are certain programs we provide that don't have any margin associated with them, an enormous community benefit being provided. So it's not that I'm trying to target a particular margin that's the right number, other than to say without any margin, we don't have any dollars to reinvest in community benefit, reinvest in the workforce, reinvest in new clinical programming and designs. So I think that the issue for the hospitals is we need to have financial stability. And a number of the programs and initiatives that have been initiated in other states around malpractice and some tort reform have been demonstrated quite effective. So really the dialogue we want to engage in as the hospital field is to say, what can we do here to get that level of stabilization, while also understanding that patients and families need to have recourse and need to be able to have a path if there has been medical malpractice, if there has been avoidable harm to a patient. So it's not that there's an ideal margin, but all of the dollars that might otherwise go to these excessive settlements or these excessive claims paid could be reinvested in other ways that could be more beneficial to the communities at large that we're serving.
Maybe Dr. Evans might know, because MedStar, I assume, is outside of Maryland. Is this nonprofit sort of controlled profit margin, is this what we normally have? Is this common in other states?
I mean, I would give you I'll give you the range. I mean, obviously, hospitals can range from almost 0% margin to up to a 8, 10, 12% margin. Those would be high for not-for-profits. I think to Ms. Bayless's comments, reinvesting in this, I think the challenge, I didn't do complete service to the senator's prior question, Delmer Erickson. The real reason that they're leaving this region is because of the unpredictability of the market. And so Ms. Bayless, to run Luminous Health, she relies heavily upon predictability around margin of what we can reinvest into diabetes, opiates, maternal and child health, all of those things. This now, when we say it destabilizes, there's no predictability for what next year looks like because we continue to erode away at these really small margins. And that's the thing that scares people away out of the state of Maryland.
So if we had perhaps a 4 or 5% profit margin allowable, do you think that insurers might sort of reanalyze their reasoning for leaving our state?
I don't think it would have any impact whatsoever. I don't think there's, again, back to Tori's comment, I don't think it has a real impact on the margin size. I think for them is how much they're going to pay out and whether they're taking the next layer beyond our deductible for 5 million or 10 million. And then they're simply on the hook for 10 million or 15 million in the next layer. If they know that those cases are more frequent in the state of Maryland, they're not going to stay here.
Okay, thank you very much.
Last question for this panel, Delegate Robin Lewis.
Thank you, Mr. Chair. Thank you to the panelists. So my fellow HGO colleague, the good Delegate Krebs, touched on the issue of Maryland's special model, the total cost of care model, which establishes basically an upper limit on the state's contribution for hospital costs and sets rates. And that's something that makes us unique. I was struck by the subsequent discussion where, we all acknowledged the special and unique health policy conditions that are operating in Maryland that affect hospitals and delivery of healthcare. But then we completely moved on, and I heard a lot of general comments about Maryland having in common with states like New York, Connecticut, and Rhode Island. We share with those states a lack of attractiveness to these big insurance companies. They're abandoning Maryland, but they're also abandoning New York, Connecticut, Rhode Island, and perhaps other states. So if we're so unique with our total cost of care model, what is it that we have in common with these other states who are also seeing an exodus of these malpractice insurance carriers? And I think it's fair also just to mention for our colleagues who weren't steeped in health policy like some of us, it's really worth mentioning that health policy it's a Rube Goldberg machine. Or actually, no, that's not even the best metaphor. There's probably a better metaphor someone in this gathering will have. It's like if you touch one component, there's no way to predict how the other components will respond. So what is it about us that, despite our uniqueness, is driving these carriers away?
So Delegate, if I could take a crack at that. Thank you for that question. So what's driving them away is the unstable liability market. And that's what the report has indicated. And you had alluded to the model, and Ms. Bayless, Commissioner Bayless mentioned this earlier, that unlike hospitals across the country, in Maryland, our hospitals are operating under fixed global budgets that are set by the state. And so we can't grow volume to grow revenue like other hospitals can. When we go back to the previous question around the margins, hospitals' median margin right now statewide is about negative 2.4%. And so the insurers aren't really leaving because of that. They're leaving because the market is unstable because of the challenges that are outlined in the report. And so we can't speak to kind of what's happening in other states, but what we can say is that the report very clearly stipulates that although there is a national hardening of the market, and this is a direct quote, Maryland is particularly affected for those
Thank
reasons.
you, Mr. Frazee. And Mr. Chair, if I may take a half of a bite of the apple, because I think it's worth digging deep, and this touches on the comments of my good colleague, Delegate Davis from Prince George's. It's not about the birth injury liability. What really jumped out in the report was the non-birth injury liability, the volatility in that area, if I understood correctly. So what is it that's happened in the past during the period of the study? What has happened that's driving the volatility and the instability? What's going on? Because our total cost of care has been in place during the more or less the same, the same amount of time as this phenomenon we're all discussing. What's going on? Are people sicker? Are providers making more mistakes? Is the health, overall health of the population declined somehow? And here at the same time, this is happening. Maryland was one of the first states to stand up its own health exchange. We have one of the best Affordable Care Act, Obamacare exchanges in the country. We should be very proud of. We've expanded access to health insurance. We've lowered premiums. We've seen an improvement in overall health status, barring COVID, among Black and Brown communities. And so why is this happening? And that's the last thing I'll say, and I'll take your question off the air, as they say.
Thanks, Delegate. If I could just say, over the last few years, we've been talking about these challenges before the committees, and that's why we've been pursuing legislation. I think our ask to you all is let's put some experts around the table and identify a reasonable solution that can stabilize the market, but also make sure that patients and their families have the compensation they deserve and need. And so these challenges are real. And I think Commissioner Bayless was about to jump in here too and may be able to speak to a more specific level, but just on a broader scale, I did want to say we hope that we can put some experts around a table to identify a solution to this problem.
Thanks, Brian, and thank you for the question, Delegate Lewis. I think that the challenge we have is we haven't had that opportunity to get around the table and have a meaningful dialogue about what interventions legislatively and otherwise, health policy-wise, might improve the liability climate here in the state of Maryland. We've done a number of great things, as you enumerated, and we do have this unique model. However, the tort environment in Maryland is very unfriendly. And these cases are very large, even though the quality and the outcomes in Maryland are not worse than what we would see elsewhere in the country. In fact, in many instances, it's actually better. So there is a highly organized effort, quite frankly, around the plaintiff's bar, and these cases have accelerated significantly over the past several years, despite some improvements in quality. And I don't want to suggest that there's not a lot more work to go. There certainly is. We are committed to focusing on quality and safety, reducing disparities, but we have a very different environment than many, many other states in the country. And if you think of New York and Connecticut, they would be more like Maryland in terms of their tort environment and perhaps a lack of productive dialogue with the players around the table to improve and stabilize for the benefit of making additional investments in our communities from a healthcare standpoint.
All right, we thank you all very much. That'll conclude this first panel, actually the second panel. But we're now going to go to panel from the Maryland Association for Justice. We're going to hear from Kelly Donahue, George Tolley, and Jay Angoff. They're going to have 30 minutes for their remarks. We're going to start at 2:53. We'll be done they need to be done with their remarks. At 3:23, I will gently commend the Hospital Association for actually being done with their remarks after 20 minutes and challenge the MHA to match them. Can't hurt to try. So anyway, we will hear from them. After this, both sides will be given 15 additional minutes for response as they deem necessary. If they don't think it's necessary, that's absolutely fine as well. Before I do that, Chair Kelly, you're on mute. You're muted, Chair Kelly. Chair Kelly, we can't hear you. We can't hear you, Chair Kelly.
I regret that we have scheduled a voting session for 4 p.m. And so members of Senate Finance will need to leave in time to be in the committee room at that time. Thanks.
That's fine. We appreciate that. We'll try and keep this moving as best we can. So who would like to go first? Ms. Donahue?
Good afternoon, ladies and gentlemen of the committee. I'd like to thank the various members of the committee, chairman, vice chairwomen. Thank you for having us here today. My name is Kelly Donahue. I am with the Maryland Association for Justice. Mr. Tolley and I, as a first measure, we're actually going to turn the table over to Jay Angoff. I'd like to give you a little bit of background on Mr. Angoff. Mr. Angoff is an attorney. He served as the Deputy Commissioner for the New Jersey Department of Insurance. He served as the Special Assistant for Health Insurance Policy in the New Jersey Governor's Office. He was the Director of the Missouri Department of Insurance. He has served in the United States Department of Health and Human Services in a number of roles, including as the Director of the Office of Consumer Information and Insurance Oversight. And Mr. Angoff has had an opportunity to review all the materials we're here to discuss today. You have a report in your submission package from Mr. Angoff, and he's going to take the first 15 or 20 minutes of our panel and tell you what he thinks.
Go ahead.
Thanks, Kelly, and thank you, Mr. Chair and Chairs Smith and Kelly and Pendergrass and Resnick. I appreciate the opportunity to testify here this afternoon. Kelly left out the most important thing, which is that in talking about me, which is that I'm a resident of Montgomery County. And also I was a consultant to the Maryland Insurance Department in connection with the proposed and ultimately turned down merger between Care First and WellPoint in the early 2000s. I'd like to talk about three issues. The first issue is the data that is available publicly. The second on medical malpractice. Second issue is about the data that the non-public data that is in and relied on in the Milliman report and how that compares to the public data. And third, I'd like to talk about the proposals in the Milliman report. Although Mr. Coker said he's not advocating any of these reforms, I think it's important that the committees know about how those reforms, what effect those reforms have had in the jurisdictions in which they've been enacted. So first, let me talk about the public data that's available. The Maryland Insurance Administration, under both Democratic and Republican administrations, does a great job each year of putting out a report on the state of the Maryland medical malpractice market. And they do it based on the data that is submitted and verified and must be submitted. And what they have found year after year is that the Maryland insurance, medical malpractice insurance, is in excellent shape. Last year, they found that medical malpractice claims have gone down consistently since 2013. Medical malpractice payments have gone down consistently since 2013. And they concluded, and this was just a few months ago, that overall medical malpractice insurance premiums have again remained affordable and stable in Maryland's market over the past year. And they further concluded that the stable rate environment and the continuing availability of coverage in the Maryland market are positive indicators for healthcare providers. They found that in Maryland, 63 insurance groups wrote malpractice coverage in 2020. Now, in addition to the Maryland Insurance Administration's data on malpractice insurance in Maryland, the National Association of Insurance Commissioners, the NAIC, puts out a report every year, a state-by-state market share report, where it goes through and tabulates, again, based on information that the carriers must file with the insurance commissioners, tabulates the premiums and losses, how much they've taken in and how much they've paid out. And what the NAIC found in 2020 was that the loss ratio is simply the ratio between the amount that insurers pay out and the amount that they collect in premiums. they found that the loss ratio in 2020 nationwide was 57. That is really, really good. What that means is that for each dollar the insurance company takes in, it pays out, the insurance companies, malpractice companies as a whole take in, they pay out only 57 cents on that dollar. Now, the other 43 cents is in profit. They've got expenses, and they're entitled to a profit. But when your loss ratio is 57, that is pretty good. You're making a lot of money. How did the Maryland carriers do? The Maryland carriers did even better. The Maryland carriers only paid out 53 cents on the premium dollar, leaving 47 cents left over for profit and expenses. Now, you've heard from Milliman and the hospitals that, well, that information is completely irrelevant to the hospitals because that's not hospital coverage. Well, that's not, to state that is to put it charitably overreaching. It is true that hospitals, because obviously they've got more money, more capital than doctors, they can afford to self-insure much more than doctors can. But there is a lot of hospital malpractice data in the MIA database and a lot of hospital malpractice data in the NAIC database. In fact, in Maryland, the largest carrier, the largest medical malpractice carrier in Maryland, which is MCIC, it's a risk retention group, which is a special type of insurance company. They're a hospital writer. They're not a doctor, a physician writer. They're a hospital writer. And you've also heard testimony about how, well, Maryland's so much worse than the rest of the country. MCIC does most of its business, essentially all of its business, in 3 states: Florida, New York, and Maryland. Its loss ratio in Florida and New York is 93. Its loss ratio in Maryland was 64. So we find that the data from both the MIA and the data from the national data from the National Association of Insurance Commissioners is completely contrary to what you've heard in the Milliman report. Now, what does the Milliman report say, and what is that data based on? The Milliman report is mainly based on what they acknowledge is internal Milliman data that, unlike the NAIC data and unlike the MIA data, is not available to the public. It's not verified. It's not audited. It's simply data based on a survey, based on a 1-page survey, which they have an appendix in the report, asking the hospitals to answer a few questions. There's no monitoring. There's no, the hospitals don't have to answer, and 80% of them didn't answer at all. Only 65% of the hospitals, accounting for only 65% of the births in the state, answered, and there's no check on their answers. So it's not very reliable data, and it's not disclosed. There are standards that actuaries have to comply with. They're called actuarial standards of practice. And the most fundamental one is when an actuary does a report, he or she must include enough data in that report so that another actuary can look at that data and make an informed decision as to whether he or she agrees with the actuary that's done the report. You can't do that in their report because you can't see the data that they're relying on. Now, you've heard a lot of discussion about the issue of hospitals retaining more liability. And there's no question that hospitals, or at least some of them, do retain more liability. And I think there are three reasons for that. One is that hospitals now, they're not really hospitals, they're hospital systems. They've got a lot more money. They can afford to self-insure. And so on the one hand, you hear from the hospital side of the debate, they argue that, well, the insurers don't want to sell to us, don't want to give us as much insurance as we want. On the other hand, if you read the insurance trade press, the insurers sometimes complain that they're trying to sell to the hospitals, but the hospitals don't want to buy from them because the hospitals now, as opposed to 10 years or 20 years ago, can afford to self-insure. So that's one reason that some retentions are going up. A second reason is this. There are some cases where the hospital simply has bad safety practices. I don't want to demagogue this issue. Obviously, there's got to be medical negligence. There's no getting around it, and I don't want to overemphasize it. But there are certain cases where insurers, in my view, and I'm not overly sympathetic to the insurance industry, but there are certain cases where the insurer is correct in not wanting to retain too much liability on behalf of an insurer. For example, you're probably familiar with the Johns Hopkins incident, not in Maryland, but in Florida, where, and this is a quote from a Florida paper, the problems in the all children's heart surgery program began after Johns Hopkins took over the hospital in 2011 and made a series of personnel changes. Nurses and other frontline workers began noticing unusual complications as early as 2015 and warned their supervisors that children were being injured or dying after straightforward procedures. But the surgeries continued. As a result of Johns Hopkins' conduct in that case, there was a $40 million payment made, a series of payments amounting to $40 million. That was deserved, but on the other hand, that was a payment made in Florida, not in Maryland, and Maryland and the Maryland market should not be blamed for that. So that's a second reason. Sometimes hospital practices do not merit an insurer retaining a great deal of the hospital's risk. But the third reason I think is this, and this is the most fundamental one, and that is the corporatization of medicine and the fact that hospitals today have a lot more risk. Not only have there been all these mergers, but they've bought up so many doctors' practices. So now doctors who used to be sole practitioners are in a doctor's group. They're now employed by the hospitals. And so hospitals are now responsible not just for what used to be their hospital liability 10 years ago or 20 years ago, but they're also responsible for the liability that doctors used to pay for themselves. So of course, they're going to have more liability. And of course, insurers are going to look at them, take a little closer look because they can have more liability by insuring them. So those are the substantive issues, and you can decide whether to believe the public data from the MIA or the NAIC or the non-public data that Millman's talked about. Although before I leave that issue, I'd like to mention one other piece of data, which is this. There's also something called the National Practitioners Data Bank, which is administered by a division of HHS called the Health Resources and Services Administration. And you heard earlier that, like the MIA, that data bank has no hospital liability. It's only doctors. That's not true. Once again, hospitals can self-insure, so there's more doctor data in it, but there is hospital data in it. And what that, and again, it's state by state data. And that data does show that Maryland's experience is worse than the national experience. It shows that Maryland's experience, for as far as the median payout is concerned, is 16% worse than the national average. And the mean payout in Maryland is 3.5% worse than the national average. Not the 75% that Milliman comes up with based on their non-disclosed data. But more significant to me is, of course, Maryland and the Mid-Atlantic region is going to have higher payments in general than the country as a whole, because everything costs. I don't have to tell any of you that everything costs more here. So of course it's going to be higher. So to me, the most appropriate comparator is, how is Maryland doing compared to the states in this area, the states it borders on? Let's compare Maryland to Pennsylvania and West Virginia and DC. And what we find is that of those 5 states, Maryland plus the 4 states surrounding it, the Maryland payments, whether you look at the median or the mean, are the second lowest in its region. The second lowest. Not 75% higher, the second lowest within the region, and about the same as national. That's what the public data show. The third point I'd like to make, and I think this is the most important, which is this. Again, regardless of whether you believe the public data put out by the MIA and the NAIC and the National Practitioners Data Bank, or the non-public data, which Milliman relies on, the proposals that Milliman recommends, such as getting rid of the collateral source rule, putting caps on damages, on the other microforms, they have been proven not to work. And they've been proven not to work in several states. Number one, let's look at California. And this is the one issue that I agree with the gentleman from Milliman on. If you look at his graph that shows MICA starting with 1975 and what medical malpractice payments were in California compared to the national average in each year since then, you'll see that after MICA was enacted, payments in California and payments countrywide went up at about the same rate until 1988. And in 1988, payments on the national level continued to go way up. Payments in California really leveled off. Okay, so what happened in 1988? In 1988, California enacted an initiative, which I worked on, called Proposition 103, which very substantially regulated the property casualty industry, including medical malpractice carriers. It's very regulatory, it's very prescriptive. You can certainly argue either way on it, but there's no question but that Prop 103 had the effect of holding down malpractice increases after 1988. MICA had no effect because after MICA was enacted in 75 until Prop 103 was enacted in 88, malpractice rates in California continued to go up just as they did in any other state. California is not the only example we have, though. It's easy to make these projections. Actuaries are in the business of making projections, and what projections are guesses. They're educated guesses. They're guesses by people who are trained to make guesses, but they're guesses. They're easy to make, and what they are vary significantly based on the assumptions that the actuary makes. There are any number of reasonable assumptions. Anyway, based on these assumptions, actuaries consistently make projections of what's going to happen to rates if our proposals are enacted. There's a famous incident in Florida from 1986 where the biggest malpractice carrier in that state, the St. Paul at that time, said, we want tort reform. Here are the tort reforms we want. If you do this, rates will come down. The legislature enacted tort reform, including getting rid of the collateral source rule and capping damages. And after it enacted tort reform, the insurance department in Florida asked each company to refile their rates to show the effect of tort reform. And what the St. Paul did was they filed their rates and they said caps on damages, the cap on damages, and the elimination of the collateral source rule is going to have no effect on our rates. That was not a unique circumstance. That's happened in other states. And I'm not going to go through and read all these, but that is typical. In Washington State, State Farm came in 1986 after Washington enacted tort reform and said, we believe the effect of tort reform on our book of business would be small. The lost savings resulting from the non-economic cap will not exceed 1% of our total indemnity losses. A company called Great American West came in and says it does not appear that the tort reform law will serve to decrease our losses, but instead it could actually increase our liability. So I just close by saying that obviously I believe that the MIA has done a good job. I think the NAIC does a good job. I think the National Practitioners Data Bank does a good job. They collect public, verifiable, audited data. All that data shows that the medical malpractice industry, both countrywide and particularly in Maryland, is highly profitable, both the physician market and the hospital market. But even if you don't believe that, even if you prefer to rely on the Milliman non-public data, the key is the proposals that they advocate have been proven in California and Florida and Washington and Kansas and state after state not to work. Mr. Chair, I appreciate very much the opportunity you've given me to testify here today. I'd be happy to answer any questions.
So there's 5 minutes remaining for the trial lawyers. You don't have to use it if you don't want to.
I will.
Questions?
Yeah, I will.
Go ahead.
Only that you all. I want to thank, of course, the 4 committees for the time and the time you're spending and investing in learning more about this issue. I will say only that in years past, over the years that Mr. Frazee referenced when they introduced legislation, birth injury funds and so forth, I was involved and I sat around tables with folks from the Hospital Association, as many of the legislators on the committees represented here also did. And in 2020, we asked them for the data. We sat around a table on the 4th floor in the House office building and asked for data to prove the crisis they claimed existed. They didn't produce data then. And as you've just heard, they haven't produced data now. And so we're still waiting, and we will be happy to talk about solutions to real problems. But we need to know the problems are real. When doctors have available and affordable insurance at $1 million limits, and it's cheaper now than it was 15, 20 years ago, how in the world can it be more expensive for hospitals to insure those same doctors when they commit malpractice? And I'm going to turn it over to Ms. Donahue for the remainder of the time, but that's all I really wanted to say.
Thank you, Mr. Tolley, and thank you, Mr. Engoff, and thank you again, ladies and gentlemen of the committee. I'm going to try to compress what I have to say in 4 minutes. A couple of things I wanted to point out real quick, piggybacking on what George said in terms of data, and there were some folks on the committee that asked about methodology. Everything you heard in the Milliman report, the 2 primary takeaways, that payouts in Maryland are 75% higher than the rest of the country, and that as a result, insurance companies are requiring higher self-insured retentions, that they are charging higher premiums, and that they're extending less coverage. All of that is based on Maryland hospital survey data and Milliman benchmarks. Not a single bit of that data was produced to any of us on this call or made public in any way, shape, or form. At no time did Milliman interview a single insurance company or insurance partner of any of the hospitals to verify the accuracy of the survey data that they were provided, or to ask the pivotal question of, if it is in fact true that rates are increasing or that you're requiring higher SIRs, why are you doing that? Is that because of medical malpractice payouts, or is it because of any of the other things that Milliman happens to mention in passing in his report, which range from cyber attacks to batching to sexual abuse claims to COVID-19? But instead, we are provided with a report that says payouts are higher and there is a malpractice insurance crisis, and it's because of tort claims. So the question is, why is that? And when you go back and you look at the Health Services Cost Review Commission minutes from December 3rd, 2020, that was the kickoff meeting between the HSCRC and Milliman. The representatives from the HSCRC specifically told Milliman that the Maryland Hospital Association had lobbied the legislature for this report, that the medical malpractice insurance reform was a legislative priority of the Maryland Hospital Association, and that Milliman's report would be used as the basis for that legislative reform effort. And after that, Milliman was assigned a contract for $246,000, in response to which they have issued the report that you have before you today that provides absolutely no basic methodology and verifiable data. And in 2020, one of the tort reforms that we heard from the hospitals was, we need Daubert, because we need medical malpractice plaintiffs to put up quality experts that show their methodology, that show their data, and pass muster. The Milliman report would not hold up under the Daubert standard, but they want you to take it as true. And I have a bunch of other things to say, and maybe I'll get a chance of rebuttal. But there is one thing that I think you really need to know. You've heard a lot today about hospitals want to make sure patients are taken care of and that they get what they deserve. Well, on January 5th, 2021, the HSCRC had a meeting with Milliman. And these are not my words. These are the words that are documented and written by the Health Services Cost Review Commission in their meeting minutes. And in a conversation with the representatives from Milliman, the HSCRC asked, what would be the net result of the tort reform proposed? What would be the result of eliminating the collateral source rule? And the exact words from the Milliman investigator, and it's now being promoted today in behalf of wanting to help the patients, was, yes, the winners will be the hospitals. The claimants, the victims, will be the losers. So I would just ask you, and I'm happy to answer any questions, but I would ask you to please just take a step back, and rather than buying what you've been told today, hook, line, and sinker, ask yourself, is the data that you provide reliable?
Donahue, please
That's
wrap
my
up
time.
quickly.
Thank you very much.
All right, thank you.
Thank you.
Trying to keep the train somehow on the tracks. We have two people with questions. Start with Chair Pendergrass and then Delegate Cullison.
Thank you, Mr. Chairman. I won't help keep the train on the tracks here. I just want to say thank you to Mr. Angoff. And I want to, as the member who sat in the room with Speaker Mike Bush when he chaired the Economic Matters Committee, Jay was being modest and did not mention that he was one of the people in the room that helped us come up with a solution to the problem of physician medical malpractice way back whenever that was. And the predictions based on data from him and the trial lawyers, if you look at the reports, which I studied every year that they were put out for many years, was exactly spot on. The numbers came out exactly as predicted annually. So I really appreciate you being here today. There's no question involved. There's just kudos to say thank you for what you've contributed to this process and to two processes prior now, because we were able to do the right thing with Care First, and we were able to do the right thing with physician medical malpractice insurance. And that was based to a great extent on the facts that you brought before us. And I'm sure that this will help us going forward. So thank you. Thank you, Mr. Chairman.
Thank you very much, Madam Chair. That's very generous of you. I miss Mike Bush and Mike Miller.
Thank you very much. If we could go to Delegate Cullison now and then Senator West. Delegate Cullison.
Thank you very much, Mr. Chair. And thank you, Mr. Angoff, for your work and your study of all the information. I am having a really hard time reconciling the difference between what you're saying around medical malpractice insurance and the reinsurance programs that the hospitals were speaking to. And I'm wondering, because they're very different. You're saying there's no problem with anyone getting any malpractice insurance, and the hospitals are saying large companies are leaving us. The companies that typically provide this reinsurance are leaving us because of the hype. And granted, there may be more than one factor, but one that they mention consistently is the high rate of payouts. So can you tell me, were you speaking primarily about the physician malpractice and not the hospital excess insurance that the Milliman report speaks to? Or were you saying basically that the hospitals were misrepresenting their ability to get this excess insurance?
Misrepresenting is a little strong. I don't want to say misrepresent. I will say that I believe both the hospitals and Milliman are overreaching. Because, as I said, it is true that hospitals can afford to self-insure and doctors can't. So in both the MIA and NAIC database, there's more physician data than hospital data, but there is hospital data. And even in the light most favorable to the hospitals, it doesn't make sense to say, on the one hand, the medical malpractice market for physicians is great, but for hospitals, it's terrible. It doesn't work that way. Again, in the light most favorable to hospitals, maybe the hospitals have it a little tougher than the doctors, but I've never seen a market where, well, in any state, where the carriers for the physicians have loss ratios in the 50s, and Medical Mutual's loss ratio over the last 5 years was 33. I've never seen a market where the physician's hospital loss ratio would be that low, and the market for hospital liability be as bad as some might be leading the committees to believe.
Thank you very much. I'm going to need to study that a little bit more to really understand these relationships. But I appreciate you bringing it to light. So thank you.
Senator West, then we'll go to Delegate Hill, Delegate Arakan.
Thank you, Mr. Chairman. So, Mr. Angoff, while you were speaking, I took a quick look at your 8-page analysis of the Milliman report. The very first sentence says, according to the Maryland Insurance Administration's annual malpractice insurance report released this past September, medical malpractice insurance premiums have again remained affordable and stable in Maryland's market over the past year. You footnoted that. Thank you for doing that. The footnote is to a report of the Insurance Administration from last September. I printed that off. I've taken a look at the first couple of pages. It's clear to me that when the MIA refers to the medical malpractice insurance premiums remaining affordable and stable, what the MIA is referring to are physician malpractice insurance premiums, not hospital insurance premiums. Would you agree I'm correct in that?
No, I wouldn't agree, with all due respect, Senator, because the second largest carrier in Maryland, MCIC, is a hospital carrier. So they're two big carriers. Medical Mutual is doctors, MCIC is hospitals. So no, it's not all physicians. Physicians might be the majority, but to try to, for the hospitals to try to distance the hospital market to the extent they have from what the MIA's conclusion that the market is stable and that claims have come down and lawsuits are going down, I just don't think is credible.
Well, let me drill down just a little more. On page 3 of the report, the report refers to exhibits B through G, which provide premium comparisons and support the statement in the report that these exhibits indicate stability in medical malpractice insurance premiums during this time period. When I look at exhibits B through G, they refer to rate comparison charts for physician classes, surgeon classes, psychiatrist class, nursing practitioner class, nursing anesthetist class, physical therapist, and a dentist class. There's nothing about hospitals in those exhibits.
That's true. There's nothing about hospitals in there. And in the specialty by specialty comparisons, I would personally find it helpful if as good as the MIA report is, if the MIA did do a comparison of hospital liability carriers. They do have carriers that are insuring certain facilities, and the MIA has a great premium, a great function at their website where a practitioner can go on it and can get the premiums charged by the leading carriers in whatever region the practitioner practices in. I'd like to see the MIA add hospital data to that.
Yeah, it would be helpful. Thank you for your answer.
Delegate Hill, then Delegate Arakan.
Thank you, Mr. Chair. Mr. Angoff, thank you for your presentation. And I would agree with Senator West that a lot of this seems to be a little apples and oranges being mixed in with some grapes, not just on your presentation, but on Milliman as well. My question is, if we presume that the basic statement that the hospitals are seeing unprecedented pressure to pay for coverage for them, not necessarily their practitioners and the people in private practice or who are employed by them. If they are indeed seeing that, do you have an opinion on whether it is partly due to the pressures imposed by our unique model here in Maryland that emphasizes lowering the prices and the cost of care potentially over the quality of care? Or do you have an opinion that there may be some other factors other than liability reform issues, particularly that are being raised by the hospital?
I'm hesitant to say too much about that. I don't view myself as an expert on the areas that you're inquiring into. The only thing that I would offer is this. I was the first director of Affordable Care Act implementation at HHS. And what we constantly fought against, and I think correctly, is that lower cost care is necessarily lower quality care. I don't think that's true. I think that lowering costs can go along with increasing quality.
Thank you.
Delegate Arakan, then Senator Bidle.
So I want to just touch back on, and maybe Kelly can answer this, the Milliman study, and sort of understand, your reference to the Daubert standard was interesting as we, on our committee dealt with a lot of debate back and forth on that standard. To the fact that you don't think it would qualify under that is quite interesting. Did they adjust for cost of living? Was that even considered, I'm wondering? And what other factors, would you point out that lead us, to think that this data might not be as impactful as what it seemed like when we first heard it?
Are you asking me if there were any other considerations given to verify the data?
Yeah, verify it. And now I'm imagining, so if they didn't, include cost of living in their comparison, and so, that's a huge part of why we might be on the top end. Why I think New Jersey was quite high. And now that I'm thinking of the map or the graph in my head, it seemed like a lot of our neighbors were next to us up there that have high cost of living. So if that wasn't adjusted in their data, then we could have a very inaccurate picture.
Okay, so sort of a very brief twofold answer. Your question really is about verification of the Maryland Hospital survey data. On the one pager that Brian Frazee put up, the last statement on there says that the Baltimore City Hospital has an insurance company that refuses to insure them for excess coverage unless the hospital carries a $25 million self-insured retention. And that statement comes from the Milliman report. And I mention it because when you look at the Milliman report, there's absolutely no data citation for that statement. The statement's made, there's zero data source for it. I think it's also really important to share with you in terms, we're talking about validity of the hospital survey data. And again, keep in mind, the hospital survey data has never been produced, and the hospital survey data did not survey all Maryland hospitals. It only surveyed some Maryland hospitals. That said, I am looking at an email, and I'm delighted to share it with anybody after this meeting, dated December 16th, 2020. And it is between the principal deputy director for the Health Services Cost Review Commission and a number of individuals at that organization, as well as individuals from Milliman. And they reference having had a meeting with University of Maryland. And it was a meeting that University of Maryland requested regarding the survey. And Mr. Henderson went on to state, and I quote, mainly they wanted to plead their case, close quote. And then the next thing he says, and I quote, the one thing they asked for that I think is reasonable is that we give them, and he means by them, and I'll tell you in a second how I know them means the hospitals, not just university. The one thing they asked for that I think is reasonable is that we give them a chance to put some spin on their numbers on a call. And so as a result of that, Mr. Henderson suggested that the Maryland Hospital Association organize a meeting, and that did in fact happen. And on December 29th, 2020, Mr. Frazee organized a meeting, and it was attended by a number of representatives, claims representatives from various Maryland hospitals. And when you look at the meeting minutes from the HSCRC following that meeting, the decision was made that that meeting would not be recorded. So if your question for me is there any additional verification of the data that supports this very bold report? What I can tell you is that there's documentation that describes the data being spun, and there's documentation of a meeting during which such data was spun where a decision was made that the meeting would not be recorded. But that's probably the most I can tell you.
Wow, that's disturbing. I would definitely like a copy of that email and any information about the meeting that took place afterwards, so that we can all have a copy of that. Maybe the whole lot of us would probably like to read that. Thank you very much.
No problem.
Senator Beidel, and I think this will be our last question for this panel. Don't see any other hands at the moment. Senator Beidel.
Thank you, Mr. Chair. And this question might really be for you. But what I'm hearing is a discrepancy between the insurance numbers, the premiums between medical malpractice and hospital malpractice. I think we need the insurance companies in a meeting to hear directly from them. I'm really confused about where the legitimate numbers are coming from. Thank you.
Okay. Seeing no further questions for this panel, here's what we're going to do. We are going to continue with the plan. What was arranged for was 15 minutes for the hospitals, 15 minutes for MAJ. We're going to do just that. I'll ask members of the committees, we're going to try and get this as close to 4 as possible. Obviously, we're going to go a little over. But to the extent that you don't ask questions that have already been asked, I would appreciate it if you hear something new you want to ask a question about, that's fine, but I'm going to need you to be super succinct as we try to be courteous of everyone's time. So to that end, we're going to start with the Maryland Hospital Association. I don't know who would like to speak first, but wait a minute. Chair Pendergrass would like to take a step in really quickly and say something. So let's do that. Chair Pendergrass.
Thank you, Mr. Chairman. It's not about your leadership in any way. It's about giving some predictability to my committee and what's next. I don't think there's any way we can start our hearing at 4 o'clock. So I'm going to ask my staff to let people know that we will start it at 4:30. I will let my committee members know that they will probably want to walk out of this at 4:15 because we need a few minutes before we go on to the next thing. So that's what I recommend to my members, and I will be doing that. And I thank you for your indulgence here.
All right, so to that end, and to riff off of the good chair of HGO, I think what we'll try and do is both sides are going to get 15 minutes. I am going to limit the time for questions afterwards so that we're going to be done at 4:15. So that'll give us 35 minutes. Both sides is going to get about 7 minutes for questions after the end of the 15. Senator Smith is going to make an announcement to his committee at the end of everything. And let's get underway. So for the hospitals, go ahead with your 15 minutes starting right now.
Great. Thank you, Mr. Chairman, and the rest of the committee members. So I promise I will be brief. So a couple of things. First, overall, there have been a lot of questions from the previous panel about the validity of Milliman. Milliman is a nationally recognized firm whose work was overseen by HSCRC, which is a state agency. They have actuarial standards that they must comply with. And this is an independent report from a firm that doesn't have a horse in this race, if you will. HSCRC is not here to speak to the assertions that were made about the work that they did or the consultant whose work they oversaw. And I would suggest if there are questions about the standards that Milliman followed, that perhaps they should follow up with the committee so that you all can see exactly what that looked like. I also did want to address the comment that Ms. Donahue made about the emails and the meeting that we convened, which is true. In fact, it is referenced in the report itself. And HSCRC asked us to convene members for a group so that we were clear about the data that our members needed to present to the actuaries so that they had what they need to do their analysis. So that was more of a streamlining issue. I'm so happy to share more about those activities, but the assertion or implication that we were somehow trying to bias the report in that way, I think is unfounded. We were simply providing the information that was required of us from HSCRC and the report. I also wanted to address Mr. Engoff's points on the NAIC. The report clearly highlights the reason that data should not be the definitive source regarding our hospital reinsurance climate. That data excludes most retained risk mechanisms and offshore excess insurance. Mr. Engoff referenced the annual MIA report on medical malpractice insurers. And again, this has been raised several times throughout the briefing, including in some of the questions that were just raised. I want to be very clear that the Insurance Commissioner of Maryland does not have loss data for self-insurance programs, which is the subject of this briefing and the report. Those self-insurance programs are not insurance companies, and so their losses are not reported to the Maryland Insurance Administration for consideration in that report. That report is focused solely on physician medical malpractice, which is a completely different market from what we're here to talk about today. He also had mentioned that the MCIC, as part of that discussion, and they write primary coverage. So primary coverage is the coverage before the excess insurance kicks in. So again, I know this gets very complicated in terms of how these different markets interact, but we are talking about a very specific market here. And Mr. Engoff's presentation does not address the market that is the subject of the report. And I think he himself, even after being questioned, admitted that MIA does not have that data. And so we would like to caveat that any discussion about using it be met with question. And same with the National Practitioner Data Bank reports that was mentioned. They're only for payments that are made on behalf of providers themselves. Again, not payments that hospitals make. So they're not attributed to providers. I think the last thing that I wanted to touch on before I turn it over to Commissioner Bayless, if she has anything to add, is around the talk around collateral source and the California MICA provisions that they focused on. Mr. Tolley had made a comment about the meetings that we had back in 2020. And we provided a significant amount of data on several occasions, both to the Maryland Association for Justice as well as the legislative leadership. We are happy to recirculate that if need be. It's outdated now, of course, but we did come to that table and hope that we'll have the opportunity to do that again. And while we look forward to our bill hearing on collateral source later in session, by no means will we be saying that that's a silver bullet to addressing our liability climate. We are not advocating for the MICA provisions to be adopted here in Maryland. Again, to be clear, we're interested in bringing experts together, as the chairs have committed to, so that we can figure out the best path forward. But from our perspective, this report clearly stipulates that we need meaningful action to fix our broken system. So with that, I will stop and turn it over to Commissioner Bayless in case she has anything to add.
Thanks.
As well as Dr. Evans, I apologize.
So thanks, Brian, and thanks for the opportunity to be with you all today. It is confusing, and I think that there's a lot of scrutiny around the data, and I do know that as the hospitals were responding to be able to provide data for the Milliman independent report to be compiled, there was a need to have uniformity in how that data was reported. So you didn't have, 46 different versions, so that there would be consistency, and that the hospitals were attentive to the direction of the actuarial firm and their methodologies, and so that there was a consistency there. I would just maybe reiterate, within both MIA and NAIC and the National Practitioner Data Bank, there is some hospital data, but it is very limited. So to the questions some of the delegates and senators posed, those data sets are largely focused on physician insurance and not this book of business that we're looking at specifically for the hospitals. So we're happy, again, we want to be able to come to the table and be able to have meaningful discussion about trying to take the temperature down and to really have meaningful reform in Maryland, to be able to give more stability to the hospitals, and also to be able to ensure that patients and families are definitely have recourse, and that they have an avenue if in fact there has been malpractice or avoidable harm to a patient. So again, thank you for the opportunity, and I'll turn it to my colleague, Dr. Evans.
Thank you, Ms. Bayless. Just as an example, within the MIA, MedStar Health self-insured captive is not inside that database. And so it just gives you an example. And I think we're talking about two completely different markets here. One is the individual physician practice. And I think the senator previously had outlined that it's all related to physician practice. There is some hospital data, but there's very little big health system data that sits inside of that. And the second thing, Senator Beadle brought up the issue around having a conversation with the insurers. I think it would be an incredibly brilliant idea. Have a conversation with Zurich and actually understand why they left the market, and they can tell you explicitly why they left, because it was so challenging. Have a conversation with Swiss Re. Have a conversation with Munich Re, CNA. They can tell you exactly why they left and give you a good sense of what the marketplace looks like in this region, even compared to other regions within the rest of the country. I think it would be incredibly valuable. Thank you again, Mr. Chair. Thank you all.
Okay, that's fine. Are there any questions based on what they just stated? Delegate Cullison, then Senator Hedelman. We're going to start the 7 minutes now. Delegate Cullison.
Thank you, Mr. Chair. And so I'm wondering if someone from MHA can explain why the physician malpractice insurance market has leveled off and is stable, but the hospital insurance, the excess insurance programs have not. And if you can explain that, that would be helpful. Thank you.
Sure, Delegate. I might actually ask either of the other two panelists to address that.
So Delegate Cullison, it's a great question. 95% of physicians now who leave graduate medical education do not go into independent practice. They join a hospital or a healthcare system. So that whole generation, and that's been going on for a while now. So what you're continuing to see is a smaller reduction in actual private practices or independent practices. Most are really attached to hospitals or healthcare systems. And it's not around corporatization. I want to be very clear. It's around population health management of a care continuum. That's a really important point, because when you're looking at providing services from the point of in a hospital to a bed to an office to home care, care continuum models like Tori Bayless was talking about at Luminous or at MedStar Health or at Hopkins or UMS. They really do require wraparound services. And that's the motivation for this. It is not corporatization. That is the motivation for actually managing large populations.
I would just add to Dr. Evans' comment, Delegate, that you look at the numbers and this path towards employment of physicians, either by hospitals and health systems, large multi-specialty groups, Permanente Medical Group. It is the path that most physicians are taking out of training, in addition to those who have been in private practice and who have found some of the marketplace challenges untenable and looking for some support from health systems. So particularly proceduralists, if a private practice obstetrician has to afford their own medical malpractice insurance, it's $220,000 a year. It's a huge number. So the proceduralists in particular have looked to work more closely with the hospitals in order to keep access in the communities. We have employed more physicians over the course of the past couple of decades. So I think the remaining private practice physician market is actually underrepresented by the higher risk specialties, particularly the proceduralists, the surgeons, and the obstetricians. So I think that levels out some of what you're seeing in the physician medical malpractice market, which is really a private practice malpractice market.
And if I could just say to Delegate Cullison that the reforms that Chair Pendergrass mentioned earlier, back about 20 years ago, this legislature did pass reforms in the physician malpractice market, which also helped. And this legislature really stepped up when that market needed it most. And so we're asking now for a similar consideration for the hospital market that we're speaking to today.
Thank you.
All right, thank you. With about 4 more minutes of questions remaining, Senator Hedelman, please.
Thank you, Mr. Chairman. What I just heard from that last colloquy, it seems like we have a data credibility crisis, and I'm trying to understand how we shed light on that. So if maybe the MAH folks can talk a little bit about the information that the Hospital Association is providing, and the hospitals are providing, is internal data. And I guess they're not required to report it to anyone. So while I wholeheartedly support and agree with my colleague, Senator Beidel's suggestion that it would be really helpful to hear from the insurers, I'm just wondering whether there is any information about their experience with regard to their own insurance that you would find credible. Anybody?
I'm sorry, was that a question for the trial lawyers or for the hospitals?
No, for the trial lawyers.
All right, well, we'll get to them in a moment. So we're going to stick a pin in that question here, but we were going just for the Hospital Association.
I'm sorry.
Here, that's okay. And I may have made that a little confusing to begin, and I apologize for that. Let's go. Are there any other questions for the hospitals? I don't think I saw any more for the hospitals. All right, fine. We're going to stop right there with the hospitals. And what I'm going to do is, because now we're going to switch back to the trial lawyers, we will give them the opportunity to answer Senator Hedelman's question, and then we'll start their 15 minutes so that if they want to make any other statements, then they can do that. And then we will take any final questions and be done. All right. So if you'd like to answer that question from Senator Hedelman, that'd be fine.
Would you mind repeating your question, Senator Hedelman?
Senator Hedelman.
Sure. I'm just sort of struggling with the information, and what I heard the trial lawyers say is that they don't find the information credible that the Maryland Hospital Association has provided and that the individual hospitals have provided about their own insurance experience. And so it sounds like the Maryland Insurance Administration doesn't collect that independently. And so I'm just asking what information, whether there is data out there that you would find credible about the experience on their own internal insurance issues.
Kelly, I can answer that.
Sure.
Yeah, there's lots of data that is available to you that the department, that the MIA collects. in the annual statements that the insurers file, there's something called the 5-year historical data page, which will give you all kinds of information about how much they take in, how much they pay out, how much money they have in reserves and surplus and that sort of thing. There's also a supplement to the annual statement called Management's Discussion and Analysis, which is a narrative, which is sort of expansive. And in the past, we've had some fun with that because the insurers in their MD&As sometimes say exactly the opposite of what they're saying to the public. That is, they may say to the public, there's a medical malpractice crisis, and in the MD&As, they're saying we're doing fine. So those things are available. What's not available is the backup data in the Milliman report. I wish that we could, it would benefit everyone if everyone could have the data that Milliman says it relies on. They say they've got some benchmark data, Milliman benchmark data, and they've collected data from the hospitals, but they don't disclose the raw data. We don't know who the hospitals are. We don't have particular claims data, claims closed with payment, without payment. We don't have premium or premium equivalent data. They certainly don't explain, describe the type of case. So it would be a tremendous benefit to everyone, in particular to your committees, if you could just get the raw data that the Milliman report says it's based on. And then we can all argue about what that data show. But it's pretty tough to be able to talk intelligently. I mean, if you don't have the data that they rely on, you're left to take them at their word. And nothing personal, no offense to them or to anyone else, but you ought to be able to verify what they say, and they don't allow you to verify what they say.
All right, for the trial lawyers, Delegate Valentino Smith.
Thank you, Mr. Chairman. I'm a little confused. I appreciate Senator Hedelman's characterization of crisis of data. So for the trial lawyers, are you trying to say to us in this hearing, notwithstanding anyone's concerns about the data, that Maryland has one of two things, or maybe we have the same amount of frequency and severity of claims nationally? We're not an outlier. So there's not a problem that our frequency and severity of claims is consistent with maybe the East Coast. Or are you saying to us that we have breaches in the standard of care that are being proven to actualize themselves in higher numbers of economic damages than we see nationally?
Okay, so I'm happy to answer your question. What I am communicating is in the Milliman report, they have told
No,
you-
what you want us to understand, because you think the Milliman report's skewed. What are you trying to tell us here in Maryland?
What I'm telling you is that you have been told that the National Practitioner Data Bank is an unreliable source because that only references physician payments. That is not a correct statement. The National Practitioner Data Bank is updated quarterly. And the requirement is that any entity, whether it be a hospital or a private insurance company, if a payment is made for the benefit of a licensed healthcare provider, that payment must be reported to the data bank. So the brick and mortar hospital is not the tortfeasor, right? You go into a hospital to deliver a baby. The bricks aren't what failed to provide you with a timely C-section. It's the nurse who fails to alert the physician to changes on the fetal monitoring strip, or it's the physician who doesn't take you to the delivery, to the OR for a C-section fast enough. So every time, whether it's a private insurance company or whether it's a hospital that makes a payment, they're making it for the benefit of a licensed healthcare provider. So to say that the National Practitioner Data Bank does not provide relevant data and it's apples and oranges in this conversation is incorrect. And the reason I mention that is because the National Practitioner Data Bank, unlike Milliman that disclosed no raw data, the National Practitioner Data Bank is chock full of raw data. And it's updated every quarter. It's publicly available. Anybody can access it. And what the data bank shows is that over the last 30 years, payments made in Maryland that are over $1 million have largely remained stable. there is no skyrocketing uptick like you have been told today. What the data bank also shows you is that the median payout in Maryland in 2020 was $275,000. That's almost precisely on par with the national average. And what the data bank also shows you is that in the surrounding states, Delaware, Pennsylvania, and Washington, D.C., their median payout is hundreds of thousands of dollars more than the median payout in Maryland. So when we're presented with a report like Milliman that gives you no raw data whatsoever and specifically tells every reader we're not giving you the data, then our responsibility is to say, okay, well, where do we get data? Well, and the truth is there is publicly available data. It is the data bank, and the data bank just doesn't support the argument that claims are at, that payouts are at this exceedingly high level. What the data bank shows is that payouts have been stable, they remain stable, and they're almost directly on point with national average. What the Maryland Insurance Administration report also shows, not related to insurance rates, because I've heard some arguments today, well, that's apples and oranges, but where the MIA report unequivocally is on point with our conversation today has to do with claim filing and claims closed, which I think is the other prong of your question. And what the Maryland Insurance Administration report also shows is that claims filed remain at a market low compared to peaks back in 2012. So what I want to communicate to you is there is not a problem in terms of frequency of claims, and there is not a problem in terms of payout in claims. Where there is a problem is in terms of quality of care. The Leapfrog is a Fortune 100 company. They just put out their 2021 top 150 hospital list. There's not a single Maryland hospital on that list. In 2016, Martin McCary from Johns Hopkins issued a peer-reviewed study that said medical malpractice is the third leading cause of death. The American Medical Association tells us that there are more maternal deaths in the United States than there are in any other developed country. So if we want to have a real conversation about the problems, it's just not fair to assign the problems to the tort system. They start at very different locations.
So you are alleging that the breaches in standard of care are more severe in Maryland. You're alleging standard of care is the cause for this in Maryland.
Not that the breaches or that the damages are more severe in Maryland. There are some outlier verdicts that have been talked about. And we have somebody from MedStar who talked about Harbor Hospital. There have been 2 8-figure verdicts that were affirmed on appeal or at least haven't been overturned against Harbor Hospital, 8-figure verdicts. Now, one of them didn't include any non-economic damages. Both of those cases were defended by a law firm from Colorado for some reason. MedStar didn't rely on Maryland lawyers to defend it in court. They hired a law firm from Colorado to try the case, and they lost both cases and ended up with the 8-figure verdicts against Harbor Hospital. So there are, and we're not denying there are some big verdicts. There are other big verdicts that were overturned on appeal. And I think Delegate Hill mentioned the Levy case, which involved a physician at Hopkins, where Hopkins ended up paying close to $200 million to a lot of women who were sexually assaulted by that doctor and videotaped without their consent during GYN exams. When Hopkins made that payment, the reason they paid that much, and this hasn't been brought up yet, but it's relevant to the question you asked earlier, Delegate Valentino Smith. Hospitals have in Maryland, all of them, as you've heard, are nonprofit charitable entities. And therefore they enjoy, and Hopkins relied upon, and there was lots of talk about this back in 2020 as well. They enjoy charitable immunity for everything above whatever their insurance is. So there's never going to be a case in Maryland where a hospital says we don't have enough insurance, no matter what their insurance level might be. They're not going to have not enough insurance because their liability is capped, including economic damages, for anything above whatever their insurance is. And so if their insurance goes down because an excess allegedly won't cover them, although there are more excess companies in the market today than there were back at the beginning of the Milliman study, So there's something about the Maryland market that's attracting more companies than we had before. But if they can't get the coverage, if the coverage went down in 2020, that doesn't mean they're going to be facing uninsured liability because they can't.
Thank you. And I just leave with that. If Ms. Donahue and you are having us say that we're not outliers across the nation, insurance carriers are leaving for some reason. And I guess that's the
Yeah, and we
you don't
asked
have the
why they're
answer
leaving
to.
in 2020, and we
Thank
weren't
you.
given anything.
Thank you. Thank you, Mr. Chair.
Thank you. We kind of got into a situation there where I've been running the clock, to be honest, because I feel that, and with no, don't mean to take away totally the time for the trial lawyer's rebuttal, but I feel that in their answers to those questions, I believe they basically have restated the arguments that they've made before. I think that unless there is something you would like to say that's a little different, it doesn't look like you do. I think that I don't see any further questions, and I think we could bring this to an end.
I would just like to thank you all for your time and your patience
Sure.
today. I know it's been a long afternoon.
Thank you very much for saying that. I think Senator Smith, go ahead.
Thank you, Mr. Chairman. And just for JPR, we are not going to be voting tomorrow at 8:30, so we are not voting tomorrow. Just need to say that publicly. Thanks a lot, Mr. Chairman.
All right. I believe that we finished a little bit behind where we thought we were going to, but thank you all very much. I think we're all going to go and take a little bit of a walk now. But this has been a joint hearing of the House Judiciary, House Government, Health and Government Operations, Senate Judicial Proceedings, and Senate Finance Committees on medical liability. We thank you very much for watching today, and thank you again. Bye-bye.